Investigación, colaboración internacional, haciendo la diferencia.
Hoffnung, Zusammenhalt, Verbesserung.
Umoja, upendo na uhai.
Science, passion, leadership.
Solidaridad, diversidad, inclusión.
Hỗ trợ cần thiết, hợp tác.
跨越邊界
oltre i fusi orari.
Without politics.
愛、協力、希望
hope, collaboration, research, data on best practice.
Ladies, gents, friends across the world, welcome to the COVID Critical Care Symposium, November 2021. It's been 18 months since we started this vast amount of work, and we acknowledge you too for the huge sterling effort that you've put in to create this family that's now brought together 35 million data points across the world. It was 18 months ago that we started it, and we're now up to 18,000 patients because of you. This is all because of you, and this celebration, I guess, is to thank you and let you see what you have created for your friends and collaborators across the world in our cathartic confessional that were those Thursday evening, Friday morning chat. The aim of today really was to spend a couple of hours, as you've asked us, to go through the highlights. Things were moving so fast at the beginning. So it's really a chance to hear from you, the summary of the data and the work that you've created, and hopefully the change that together we've created across our global network of 400 hospitals and 55 countries. So please sit back, relax, pat yourself in the back, have a drink if it's an appropriate time, and listen to what you've created with the COVID Critical Care Consortium. So, ladies and gents, it's my great honour to open this meeting to you. I think we've all become accustomed to doing Zoom calls in odd places. Tonight, you know, when I started reflecting on what this was about and the fact that I was meant to be at dinner at the same time, I think this is about how we have managed to fit in our normal lives somehow, in some way, together with trying to make a difference across the world. When we started, we had no idea of what we were going to create or who we would bring together. We just knew that here in Queensland, where we had really no burden of disease, and we still don't have a burden of disease, that we had a responsibility to try and help in some shape or form. I guess at the start, it was our colleagues across the Asia Pac, when the disease kicked off across Asia Pac, asking us how should they ventilate or how should they dialyse. And realistically, we had no idea how to assist people. Then we brought a group together to start talking about it, hoping that this disease may finish in the Asia Pac, as the Asians have managed to contain SARS-CoV-1. Unfortunately, that was not the case. The disease grew, and with that, so did our consortium, and so did the global family. Initially, the purpose was really just to try and gather data, which is what we've done incredibly well, and we're now up to about 18,000 data points. But it became much more than this. It became a place where people could come on a Thursday or Friday evening to ask questions, because none of us knew the answer. Asking questions, getting observational data, getting expertise from across the world. It's grown, and it's been fascinating talking to you, our colleagues across the world, to see what it's meant to you. We showed those videos at the start as to what it actually meant to you as we kicked off, but it's become so much more. And I think, you know, whilst COVID has stopped us all traveling, and I for one hate it, still desperately keen to see my mum, who I haven't seen for 2 years in Scotland, it did allow us to actually open doors to friendships, to collaborations, to relationships that we hadn't had before. One of the wonders, I guess, of modern communication, that sitting outside this restaurant. I'm on a phone before I get to the lab shortly to help my team with Chloe, who's run this so incredibly well. So we didn't know what to do at 18 months. And we spoke to you, as we always do, our colleagues across the world, and said, what do you want? And people said everything was moving so fast at the kickoff of this consortium. Most people can't remember. I know, whilst we didn't have any disease here, we were just working like bats out of hell, trying to get things together from an administrative point of view to try and assist you guys who are doing the real work across the world. So the purpose of tonight was really look back on what we've created, learn from our colleagues, whether you're from India and Hi Arpan and our colleagues from Kuwait. And we've got over 550 people that have linked up for this. That's phenomenal when you think of how bored we all are with Zoom calls. But I think we have created something special here. As many of you have heard, the Gates Foundation have now come and joined us and said, look, what your team, and it's not us in Brisbane, it's you across the world, what your team have created is something special. Not just the data and the ability to bring 18,000 patients worth of data together, but a dashboard, be able to share it globally for nothing, real time across the world, is a different way to do it. So as we see these messages flick across the screen, whether it's from Kuwait, whether it's from Ireland, whether it's from India, whether it's from Australia, it's a time to sit back, hopefully, and relax and enjoy, whether it's a coffee in the morning, whether it's a Chianti if you're Italian in the afternoon, or a Shiraz here in Australia at night time, to listen to your colleagues, who I think we've all become friends, a bizarre friendship, I guess, shared across Zooms. But sometimes, you know, we've spent more time on Zooms with people than we've ever spent with them at meetings in the past. So I'm going to be online till 2 in the morning here. We've run it. We hope that it's as useful a time as those of you from the rest of the world. So we are, our Saturday evening goes from, I think, 9 at night from 2 in the morning, so that we can try and get as many people across the world, because it's you that have done the work. Melbourne and Sydney here have done a fair bit of work, but Queensland, where we're based, have done literally nothing. So this is a celebration of what you've created. And I guess this is a call, when we go back to normal world, please God, whenever that is, that we can do better, as we've done so incredibly well. The concept of I is really dissipated within this kind of research forum. I've been humbled by being part of it and being allowed to be involved in a lot of it. So an amazing pile of speakers are joining us, and it's just great seeing all these different countries joining online. The steering committee, I think, has to take a bow as well. So behind the meetings, behind the papers, behind all the financial arguments, behind the legal discussions with universities, there's been a great team. Our team here in Brisbane, I'm just going to give them a bit of a shout out. We've really done no clinical work at all to do with COVID. But in terms of running this, it's taken, running, as you can imagine, 400 odd hospitals has taken a huge amount of administrative power. It's not very sexy, it's not very cool. It's not going to get into the New England JAMA or the Lancet, but without it, we wouldn't have been able to come together. So to our colleagues across the world, I'd like to just, on your behalf, say thanks to our team, thanks to Chloe, young Chloe, who joined us about 6 months ago and has put this program together. Thanks to Lauren, thanks to Hannah, our manager. Thanks to my colleagues, Jackie Swen and Gianluigi Labasi, who have run this, who have created this amount of work. To our steering committee, each month on top of the our meetings, the steering committee come together to guide us, to help us make the right decision on your behalf. They've given their time tirelessly and without any kudos, just to try and make this work. So thank you to everyone. This is going to be an on and off call. I'm certain most people will not join for the entire time, but this is your creation. This is what medicine, this is the best of medicine, where we work with our colleagues together for a common purpose, with no thought really of whether it's financial remuneration or academic remuneration. This is what is the best of medicine. This is why I became a doctor. One of the other reasons I became a doctor was looking at the people that come before me. My grandmother was one of the first female medics in Ireland, fought in 1916 behind the post office against the English, and she was one of the people that inspired me. But I was just reflecting today that when I was, I think, 19 as a medical student in Glasgow, I heard this amazing man called Bob Bartlett, who was doing partial liquid ventilation at the time, and it fascinated me. I wasn't meant to get access to the room, but I did. I snuck in at the back, and I listened to Bob and was blown away by the passion and the innovative spirit. I've become, I think it'd be fair to say, friends with Bob. When we started this off, you need a leader, a proper leader. When we started, ECMO was one of our key interests, and it still remains so. But who could be better? And I asked Bob, would he mind leading the steering committee? Bob's not 21, I think it'd be fair to say, but there is no one got more passion and energy and spirit. Bob has turned up for every steering committee meeting that we've asked him to. He had his own period of ill health in the middle of it. I think he took maybe 1 or 2 weeks off, but every single steering committee meeting there. So here is a man that was at the forefront of the development of cardiopulmonary bypass, who, as you well know, is seen as the father of ECMO, but every week gave his time, gave his expertise, gave his advice, gave his humour, particularly about Mr. Trump's candidacy, to lead us. And I couldn't think of anyone more fitting to talk to us tonight and open this meeting, a celebration of what it means to be a clinician, and a celebration of how we've come together in this pandemic. Bob, I believe, is going to talk about what it means to be a doctor in the middle of, or having seen 4 pandemics. Today is a smorgasbord of academia, of brilliance, of innovation, and of selflessness. I know very few of us will get the time to sit down and listen to it all, but honestly, you should be so proud of what you've created. We here in Brisbane, with our team and Lauren, who's been helping as well, we're honoured to be able to do this. It's not a nonsense word. It's a real word. We are honoured to be allowed to be part of this. And you know, when we look back in 10 or 20 years of what we've created, I think we'll be blown away. So enough banter from me. Thank you for everything you've put in for the last year and a half. Thank you for what we're going to produce from our clinicians across the world. We get a huge amount of acknowledgement and praise that we really don't deserve here in Brisbane, but we're quite happy to take it on your behalf. So I'm going to close the opening remarks. I'm going to pass the microphone back over to our team. I'll be finishing dinner here soon. If anyone's interested, I'm having the sole with chips because I am Glaswegian, even if I'm in Australia. And I'm going to pass the microphone over to my good friend, my colleague and my mentor, Bob Bartlett. Thanks very much.
Thank you, John. And can the rest of you see me?
We can, Bob.
Thank you, John. Thank you for that very nice introduction. We have been friends for a long time. Well, to all of you on this Zoom call, it's a real honor to introduce this symposium, the first public presentation of the data and analysis from the consortium. I'm certainly proud, as all of you are, to be participating in this remarkable venture. Now, let's see if we can make the screen share work. Ha! All right, good.
Well done.
So for almost 2 years now, our personal and professional lives have been consumed by managing this pandemic. To kick this off, I thought it might put this consuming experience in some perspective if we consider caring for patients during 4 other pandemics in the past. I invite you to imagine being a doctor during 4 pandemics last year, 10 years ago, 100 years ago, and 200 years ago. Imagine you're a doctor 200 years ago in 1820. As today, people expect you to know what's wrong with them and how to treat it. You can diagnose plague and cancer and apoplexy and tetanus and gangrene and so on, the treatment might be to remove a bladder stone or to remove a gangrenous leg, or more commonly, it would be to treat the patient with laudanum or foxglove or some combination of stuff put together by the local pharmacist. These medical treatments are effective 30% of the time, and patients are very grateful. You must be a very wise doctor. This year, the plague that we're worried about is smallpox, a frightening and deadly disease. The treatment for smallpox, we all know, is bleeding. Now, you might wonder why, but it all depends on the basic science that we know about. All of the world is made up of only 4 elements: earth, air, fire, and water. And the medical correspondence to those elements are bile, blood, and phlegm. If a patient has too much blood, he might have sweating, he might be hot, he might be wet, and very symptomatic in that way. And the way to treat it is to get rid of some of the blood. This happens all the time. Quite recently, a former president was bled for pneumonia. He died of the bleeding, not so much of the pneumonia. But this is what we do, and it doesn't always work, but it's our approach to, among other things, smallpox. As Galen says, this treatment is very effective if it works. If it doesn't, it's not a good treatment. So when smallpox occurs in a community, many people are infected, and about 30% of them die at that time. Those who do not die are scarred for life with horrible scars, and it affects everybody, including the Queen of England, who had such serious smallpox scars that she always wore heavy makeup and does today in her modern depictions. That epidemic is a pandemic if we were to count all the people in the world who have it. And this is just 1 year. It's been going on for over 1,000 years. So this happens all the time. In this particular year, there are 1 million cases, 400,000 die, and the fatality for this condition is 30%. Imagine if the COVID mortality was 30%. Now, there's a country doctor in England named Edward Jenner, who realized that animals and people who were affected by the cowpox condition, if they got that disease, this is a photograph from, it's a drawing from Jenner's book showing the pox on a udder of a cow. If they have this condition, they do not get smallpox. He thought that was really interesting. And in fact, he took some fluid from one of the cowpox pustules and injected it into a patient. Didn't inject it, he scarified it on the surface of the skin because he didn't know about injection. No one did that. And that little boy did not get smallpox at the next time the epidemic came around. He called this procedure vaccination after vacca, which is Latin for cow. By 1820, every doctor has a little vaccination set and can give vaccination of cowpox to prevent smallpox. A disease has been entirely prevented for the very first time. Pretty encouraging. So a bit of science, but being a doctor is mostly about caring, as John says, but here we have something to do in conjunction with the caring. Now imagine you're a doctor 100 years later, 1918, 1920. people expect you to be able to diagnose their problems and to fix them one way or another. And you can diagnose all the things we could do before, but new conditions like scarlet fever or nephritis or mitral stenosis and scores of diseases, which we now know in 1920 are caused by bacteria and parasites. In 100 years, medicine has learned that the axioms of science that we followed for 1,000 years were all wrong, but now we know how organs work, how diseases occur, and we know that microbes, very small particles, bacteria, are responsible for many of those diseases that we thought were related to earth, air, fire, and water. The people who made these changes, we remember their names. Louis Pasteur is a Frenchman who discovered the role of bacteria in all of biology. He learned how to sterilize everything from a wire loop to milk. Robert Koch, a German, discovered that bacteria actually cause diseases, particularly tuberculosis and many others. Joseph Lister, a Scottish surgeon, discovered that wound infections were caused by bacteria and in fact can be treated by antiseptics, and infection in the wound can be prevented by antiseptic materials. Here's a drawing of Lister operating on a patient with a spray of phenol to keep the field sterile. The concept of asepsis is introduced by Lister. So you have a microscope in your office. You have laboratories and X-ray and anesthesia. Your hospital has a surgical suite where you can actually do sterile operations. Quite amazing. You know that most of the infectious diseases are actually caused by something carried by animals, either as vectors or they transmit the disease directly to humans, like influenza in birds and pigs. This year, there's an epidemic of influenza, and we recognize it. It's been around before. It begins in the World War I army bases. It spreads to the big cities quite quickly, and it's very contagious and it's very serious. We know that the infection begins in a population, it goes up and up and up until we just shut the whole environment down, and it goes back down again, only to start again at a later time. So the treatment is to isolate the patients and try to keep them from infecting other patients. So the treatment simply involves putting people to bed. There's no treatment, we're just helping them be more comfortable, but the mortality for this condition is 10%. Devastating problem. Imagine if the mortality for COVID were 10%. So since Jenner, doctors have experimented with giving a small amount of infectious material to healthy people, vaccination, to prevent the onset of disease, and it works for smallpox, typhoid, cholera, works for influenza. So we impanel a lot of helpers to vaccinate people with a vaccination that we have based on stuff from prior patients with influenza. And we did a lot of that in that year. However, it didn't work because we had the wrong material. Influenza disease acts like a bacterial lung infection, but we cannot find any responsible bacteria. If we culture blood or sputum from a influenza patient and we culture it, we can culture a lot of bacteria, none of which seems to be the cause, but we use a device called a Chamberlain-Pasteur filter. It's a long tube of porcelain, and if we run the fluid through that device, what comes out is the filtrate, and it has no bacteria in it. So what we have learned is that that filtrate causes the disease, and in fact can be made into a vaccine, but we don't know why. If we look at the statistics from that influenza epidemic in 1918, there were about 500 million people worldwide. 50 million died of it, and the fatality for that epidemic was 10%. Now imagine that you're a doctor in 2010. That's just 10 years ago. You probably were, most of you on this call. We have new ways of making diagnosis. Now the cause of disease is, now we know, is many of these diseases are caused by viruses. Viruses were not discovered until 1935 when the scanning electron microscope came along. But we have learned that many diseases are caused by viruses, and we even know what the viruses look like, and we give them names and so on, and we can prevent measles, mumps, chickenpox, diphtheria, pertussis, tetanus, and several more problems by developing vaccines that are based on the family of viruses that cause diseases. We're actually studying a vaccine that's intended to prevent cancer, believe it or not. Smallpox, that terrible plague, is one of these viruses, but it is gone. We've eliminated it from the planet simply by vaccinating all the susceptible people in the world. We're getting good at it, so we're surprised when there's a new epidemic of influenza, despite vaccines that have been going on. And it turns out that this is a new strain of influenza. We called it H1N1, which has not been around for 50 or 60 years. So most of the population does not have any immunity to this particular virus. And so it is a major problem for the people, even for the people who were vaccinated. Influenza occurs in the winter. So it hit first in Australia and New Zealand, and the ANZIC group studied it and reported their results so that those of us in the Northern Hemisphere would be ready for it in the winter. That group did some remarkable studies, but when they had patients who were failing on mechanical ventilators and were referred to a few centers for ECMO, what they learned was more than half those patients recovered just with good care, but 68 of them were failing, went on to ECMO, a treatment that was used a lot in pediatrics, but occasionally in adults at the time. And 75% of those patients actually recovered, resulting in overall 86% survival in those hospitals that had ECMO capability. One of those was in Melbourne. And so here's the team in Melbourne. I happened to be there at that time. And here's the ECMO machine. It's pretty simple. The nurse can leisurely take care of the patient because it's not so frantic as it was caring for those patients just on a ventilator. Many studies came out of that pandemic. This is an example, patients in England who were referred to ECMO-capable centers versus centers that were not, and a big difference in outcome, as you all know. So here's the data from the influenza epidemic of 2010. 60 million people 284,000 died, a mortality of 0.47% compared to the flu epidemic only 100 years before. And the difference is some of these patients were treated, others, that is the 2010 patients, others form basically the control group. Now, you don't have to imagine being a doctor in 2021. We're living through this right now. We have this new disease. We realize that this disease is as bad as smallpox, it's as serious as the 1918 flu. It acts like any viral pneumonia, but it's not caused by the influenza virus, even though it looks like it. It's caused by an entirely new virus called the SARS-CoV-2 virus, which appears to have generated from animals, as these diseases usually do. But this is really a serious infection. Managing patients in ICUs is possible, but now the patient's very contagious. So we have to do this with full protective garb to avoid catching the virus from those patients and spreading it around the hospital. ECMO works if the ventilator fails in these patients with about 50% recovery. So the COVID epidemic, we're in the middle of it, so these numbers are not complete. But the important thing is we've learned that the mortality with all of our treatment is about 2%. It's a very serious problem. This is where John Fraser and the COVID Consortium comes in. In 2019, John was president of the Asia Pacific chapter of ELSO. And when this condition first became apparent, it was in the Asian area. And John thought we better get ready for managing ECMO in these patients. It soon became obvious that they were so sick. The question wasn't ECMO. The question was, we need to learn something about this disease. So he put together this remarkable consortium of doctors, epidemiologists, statisticians from around the world, including all of you who are on this call. And now we convene this group every month, as John says, and we get together so that Gianluigi and Jackie and others can tell us what we're learning. Now we have the data to analyze, and that is the purpose of our meeting today. So we're ready to begin our symposium. I hope you found some perspective in this smattering of history. Being a doctor is just as challenging as ever, but our primary role has not changed. So enjoy the symposium. Thank you for the opportunity.
Bob, thank you as always. What a wonderful discussion of what it's been like, what we're going through at the moment, and tonight what we're going to hear about what we think is going to happen next. We've been incredibly fortunate to have you, our leadership, and giving us the perspective of someone that's been through so many things and developed so many tools that have been so essential during this pandemic. So for your leadership, for your mentorship, and for me personally, for your friendship, thank you very much. Giles Peak, Bartlett, inspiring as always. We will hear the laudits, no doubt, continuing throughout the night. We do have a minute or two for questions before we move on. I'll just see if I can work this simultaneously from my phone. Do we have any questions coming in from the panel? It's very much a view from the bridge that Bob's given, rather than a question and answer. I think it is fascinating, though, to see how the pandemics have changed and how rapidly we've managed to adapt in this pandemic. One of the things when I spoke recently at another meeting was, I think the typhoid vaccination took almost 100 years to produce. I think the hepatitis B vaccination took 20 years to produce. and the Pfizer variant of the vaccine we've got just now, between when they signed with BioNTech in March till the first dose was given out after the randomized control trials, was 226 days. So it is incredible what we can do when we all work together. And I think that's what we've done here too, and that's what Bob summarised nicely. Look, I think we will, after Bob's inspirational opening, we will move to our first speaker. Our first speaker is Dr. Nicole White. So one of the things I find most interesting about this consortium as we move forward is how do we integrate the different people. We as intensive care clinicians are used to being kind of in charge of things, but when you start bringing these data pieces together, which was roughly our first idea, let's bring some data together and see if we can bring some clarity to it. And it became immediately apparent that doctors and intensivists, particularly myself, aren't much chop of what to do once we bring in serious amounts of data. And to get clarity, we needed serious amounts of data. So I turned to my good friend, Adrian Barnett, previously almost professional footballer, until his knee got in the way, and said, Adrian, we need help with numbers. He knows that I'm totally incompetent. We're very fortunate that Adrian brought to the group Nicole White. You know, again, my analogy has always been, if there's all these pieces of data across the world, if there's 35 million jigsaw pieces across the world, if they're not gathered together properly, they give us no picture. But if we can piece them together and bring them together appropriately, they give us a phenomenal picture of what's happening in a once-in-a-lifetime condition. And that's exactly what Dr. Nicole White, who has been a winner of one of the Science and Technology Awards in Queensland, who won the Advanced Queensland Fellowship. Nicole has come on board to our team and led from the front. We're medics, we're quite reasonable at medicine and science, but we're really not much chop when it comes to 35 million data points. So Nicole took to this and led us. She did it with a quiet calmness, a gentle smile, but a steely resolve that she kept us going in the right direction, gently pulled us up when we were going wrong, and kept us right. So it's entirely appropriate that, having heard from one of the leaders in medicine over the last 50 years, Bob Bartlett, we lead to one of the new leaders in medical technology and medical data science, because this is the future of medical data science. So I'm going to pass to Nicole. I see that there's one question that's just come in that's talking about the resources globally, whether we can pass through this pandemic, but we might leave that in the chat room just now. And we're going to pass with our thanks to Nicole, who has been one of the key workers, never complained, just kept going and kept us on track the whole way through. And as everyone says, she's been fantastic. So I'm going to pass the slides over to Nicole. And with that, Nicole, 400 hospitals and 55 countries are your biggest fans. Thanks, Nicole White.
Thank you so much, John, for that introduction. Great. So I can see a number of familiar names in the webinar this evening that I've had the pleasure to meet over the past 12 months. But if we have not met before, my name's Nicole White, and as John mentioned, I've been working with the COVID critical team here in Brisbane as a member of the stats team. So for my presentation this evening, I've been asked to give, I guess, sort of a brief perspective around the opportunities for analysis with the COVID critical database, as well as, I guess, some of the nuances and challenges that come with analysing real world data. So I'm going to start true to form with a number, and it's a big number, 16,537. So as of this week, this is the total number of unique patient records that have been registered in the COVID critical REDCap system, which from any perspective is just phenomenal. So to break this number down, this of course includes the primary data collection through the ECMO card ASARIC CRF, as well as additional patient collection through Sprint SARI from selected Australian sites, as well as the integration of related databases from both Italy and Spain more recently this year. So by definition, COVID critical is truly a global effort. So if we just focus on that primary data collection through ECMO card initially, a great strength of this database is that we have really good representation across all 6 major geographic regions. A secondary benefit of COVID critical is the coverage of our data set. So for our current cohort of enrolled patients, we have full coverage over the full course of the pandemic, of course, starting from early 2020. Something to keep in mind, though, for those considering designing or analysing studies using the COVID critical cohort is that whilst we have that broad coverage across time, quite a large number of our patients in the cohort were in ICU during the very initial stages of the pandemic or the first wave. So whilst we do have good representation, particularly within the Northern Hemisphere for their second wave towards the end of 2020, any analysis of our full cohort as it stands is really reflecting those initial management strategies and early outcomes for severe COVID-19 patients in the ICU. So from an analysis perspective, one of the key strengths of COVID critical is really its dynamic nature of data. So dynamic, first of all, of course, in terms of new patients are being enrolled all the time, increasing our total numbers. But a key strength of our database is really around sort of that emphasis that we place on the collection of date information, particularly around the timing of key events during a patient's hospitalisation. So of course, we have information on the dates of hospital and ICU admission, as well as outcomes, including discharge and death. But as you're aware, through the ECMO card CRF, we have really granular information on the commencement of invasive mechanical ventilation and ECMO. And then, of course, in addition to that, through some of our sub-studies, we have additional date time information on selected complications as well. So as a statistician from a data processing aspect, this is quite a challenge dealing with dates. Because we're always trying to make sure that for each patient that sequence of dates makes sense. But the effort is really worth it because what we end up with is capacity for more in-depth analyses that sort of go beyond that initial emphasis on final clinical outcome to really focus on the duration of therapies and how the timing of different clinical events can actually influence a patient's length of stay due to COVID-19, as well as potentially how the timing of these events might influence a patient's risk profile. So a really consistent theme that we've done with our analyses with the consortium so far is really leveraging that date information through the use of multi-state modelling. So as an example, so multi-state modelling, I should say, is a fairly recent statistical method, but it really leverages that dynamic information so it can look at the influence of different therapies on length of stay and varying risk and outcomes. So as an example, our analysis of respiratory compliance on the full cohort earlier this year focused on the duration of mechanical ventilation and how the risks of ICU discharge and death in ICU varied over time, so up to 28 days following admission. As another example of the use of this methodology, so with the neuro subgroup led by Sungmin Cho and Adrian Barnett as lead statistician, they collected information on the timing of stroke. So they were able to actually really drill down into looking at how the timing of stroke during hospitalisation could potentially modify length of stay and the risk of death versus discharge. Another key strength and a potential challenge with the COVID critical database is the level of detail or granularity in the data. So of course, I've talked about dates already, and beyond sort of that, the baseline characteristics of the cohort that we collect, a key feature of the database is that daily observation, so particularly around key clinical parameters and the use of different supportive therapies. So as you're aware, sort of at the beginning of the consortium, we collected data through what was known as the full CRF, so daily observations on these parameters. But later on, we introduced this option known as the basic CRF. So we're still trying to collect that granular data on a daily level, but instead of every day, we collected data at selected days over a patient's admission. So in terms of challenges, like whenever we're trying to set up a database like this from scratch, or for any type of observational study really, there's always this initial discussion or this tension between, do we focus on a variety of different variables or data types, or do we focus more on volume in terms of total numbers of patients? And from the outset, this is always quite a tricky question to answer from the get-go, because especially when you're in a situation such as the pandemic, where at the beginning we have very little information or evidence about what to collect in terms of modelling the clinical course for these patients. So for COVID critical, there's quite a wide variety of variables that are included in the data set. From an analysis perspective, though, a potential challenge with collecting that much variety of data is the presence of missing data. So for those on the call who have worked with the stats team before, this visualization probably looks very familiar to you by now. So what we have on the screen is a visualization of missing data patterns in the current cohort for selected comorbidities and baseline characteristics. So missing data is something that we really think through as part of every analysis, because there's multiple reasons why data could be missing in our database. In some cases, it could be completely inadvertent that a field has been missed or information hasn't been included in the patient record and subsequently entered into REDCap. But because we're at the stage of the consortium now where we actually have multiple studies with slightly different CRFs included in the database, there are cases where variables aren't collected consistently across those studies. So we have an issue which I refer to as structural missingness. And there's different ways of dealing with that statistically, but working with the clinical leads, this is something that we work through in quite a lot of detail, because a lot of these methods are quite routine, but they involve quite some strong assumptions about why those data are missing in the first place. So that's been a challenge throughout the past 12 months, but there are ways to work around it and opportunities to improve that completeness as we move forward. Another sort of source of missingness quickly, which I wanted to touch upon, was around that daily data collection as well. So the missing data patterns at that resolution is quite complex and difficult to summarize in a single figure, I guess. So I've tried to do it here. So you can see, so we have days on invasive mechanical ventilation and percentage availability for key clinical parameters over time. So the key messages from this type of analysis is that across the board, completeness is fairly good, but it does vary depending on the parameter. And in general, completeness does tend to decline slightly over time. I guess to try and turn this challenge into an opportunity. So I'm sure you've read many COVID-19 research papers by now, and a common approach that people use when it comes to looking at associations with these key parameters is to only focus on the baseline measurements, such as measurement upon ICU admission. But what we have here as a consortium is a real opportunity to take advantage of this granular temporal information. So looking at trend analysis and trying to make the most of this information in the types of time-dependent modelling that we do. So looking ahead, data completeness absolutely is improving, and this is a huge thanks to the ongoing efforts of data collectors across all of our contributing sites. In terms of sort of future priorities for analysis from my perspective, I think it's really about making the most of the key features of the current cohort in terms of the dynamic nature of the data. And also in terms of those total patient numbers, acknowledging that we have a large number of patients characterising that initial wave and fewer patients for subsequent waves. I think we're in a good position now to really start drilling down into special subgroups within the patient cohort. So this could be through the sub-studies, through their ongoing efforts, or particular subgroups of clinical relevance to you. So I think this is a really interesting opportunity for future work as we move forward over the next year. So just to end, so I'm here tonight on behalf of the team of statisticians. So as John mentioned at the very beginning, it started with Professor Adrian Bartlett, and I came along a little bit later. And for a while there, it was just the two of us working across multiple analyses with John Luigi on speed dial, so we could make sense of the data and try to understand the clinical relevance of the data set. But we've also grown over the past few months as well. So all the pictures on the screen here are our stats team, as well as Simon Forsyth and Dan Dye, who really look after us in transforming the REDCap database through to a nice process form that allows us to do our analyses. So I just wanted to say on behalf of the team, thank you to all of you who have helped us over the past 12 months to understand your data. I think as a team, we all understand that data are more than just numbers, and context is everything. So in order for us to do our job effectively, we really rely on you to help us interpret the data and answer clinically important questions. So I just wanted to end on that, and thank you very much for all your support, and we really look forward to working with you over the next 12 months. Back to you, John.
Thank you very much, Nicole. Yes, Gianluigi. Yeah, it's been challenging. I just can emphasize that from the very beginning, it's been very challenging, particularly at the very beginning where when the data were absolutely not completed. We do have at least time for one or two questions. I do see that there is one hand raised by Mary Lou. You can either write the question in the question and answer chat, or I think we can open your speaker, maybe your microphone. Well, I'm going to start with the simple question, Nicole. So our approach has been very different from an approach from other groups. Other groups, they got ready very early, years ago or decades ago, on potential interventions that could be applied to any pandemic. And as soon as the pandemic hit, they started with a big, large randomized trial, or adaptive kind of trial. And the important information we received from the group in Europe about dexamethasone was absolutely on this approach, just prepare very early and then start with a randomized clinical trial. What is your opinion on this different approach that we implemented? I think our first priority was to run a big observational study in order to understand the disease, and perhaps in the future to collaborate with this group about that they can run randomized clinical trials.
Yeah, that's a really good question. I mean, to me, I think the strength of any observational study is really understanding what's happening day to day within an ICU. So I think a big strength of the consortium is because we sort of have that global perspective. We're able to really account for that variation in different management strategies, whether that be sort of over the course of the pandemic, between geographic regions as well. So really just understanding what's going on day to day. So I think it's more of a broader view as opposed to a targeted randomized clinical trial. I guess sort of the flip side of that is that you don't sort of have sort of that strength of a randomized clinical trial through those processes of randomization and sort of that increased ability to make causal links between intervention and outcomes. So that's definitely a limitation of an observational cohort study, in my view.
Very good. Thank you very much, Nicole. So if there are no other questions, it's my honor to present the second speaker of this symposium. John, if you have time, or if you want to introduce David Thomson, or I can do it. Yeah.
So look, you know, firstly, can I just use chair's prerogative? Nicole, you know, this has obviously been a crazy time. What do you think we're going to change in the way we do data collection after this? You know, is this going to be, you know, real-time data collection, empowering it to clinicians, putting it in their pocket? Will journals become less important? Is this, if we have clean, raw data, are clinicians smart enough to be able to use this? Or must we wait still for journals? Because journals have been so slow with a lot of this. Do you think that the way that we use data is going to change through this pandemic?
Yeah, I definitely think so. So, you know, if we take the dashboard as an example of actually providing that real-time feedback to clinicians, like it is their data, and at the end of the day, they need to make decisions now about how they manage their patients. So you can't wait, you know, 6 to 12 months for a journal article to guide you about how to make decisions, because, you know, particularly in a pandemic situation, the whole situation could have changed by then. So I definitely think it will help. It will definitely change the way that we look at data. How we do that, I'm not quite sure. I think that's a big challenge that we all need to focus on for next time.
Yeah, no, I agree. And I think, you know, this is one of the things that the Gates Foundation has found so fascinating by what we've done, and by Nicole and Adrian and the stats team, by how you've empowered us. If we can do it this quickly and this effectively, do journals become secondary rather than primary sources of information on which we base our treatment? I don't know the answer to, but I think we will leave this pandemic different than before, hopefully better than before too. And a massive component, Nicole and Adrian and the team is because of you. So thanks for that. Nicole, we'll move on. Thanks very much. It's my great pleasure to introduce Dave Thomson from, and I'm going to say the name wrong because I've never got it right so far this year, Groote Schuur Hospital, the transplant hospital that Mr. Barnard did the first transplant. David has been incredibly impressive with his team over there. They've not just been dealing with the pandemic, they've occasionally dealt with civil wars, which South Africa see a fair amount of. I remember David telling me one day how people were breaking into the hospital stealing TPN. I'm not quite sure why they were stealing TPN. I've never found much of a use for it myself. But they were breaking into the hospital, stealing TPN. The cultural things that we've seen in every country is different. Again, a huge amount of alcohol-related fuel violence in South Africa, possibly more than Glasgow. And David was telling me how the first wave, they actually had more intensive care beds because they'd stopped selling alcohol in the shebeens. But by the second wave, they'd restarted selling alcohol, but put it in teapots with different coloured tea bags, one colour for rum, one colour for beer, one colour for wine. Regardless of that, David and his team over there just kept working away at a huge amount of data that they were putting in. And David's going to talk to us about what it's like in a low middle income country resource. He's worked very closely with us in a welcome grant that currently is unsuccessful, but we'll definitely get there. And he's working to try and improve how we acquire rapid data in low middle income country alongside Bonya Chifasa from Kenya. So it's been a great honour. I've still never met David face to face, but I see him as a friend that we chat frequently on the phone and WhatsApp and everything else outside the Zooms. So David, thanks for all the work. It's been phenomenal what you and your team have put in despite the way of clinical practice that you're doing. And he's going to tell us about an African tertiary centre ICU response to COVID-19. David, thank you.
Thanks very much, John, for the introduction. And yeah, I can't say this has been a virtual meetup, and the potential of this consortium and how it's grown has really inspired us here in terms of trying to analyze this data and try and get a sense for what it means for everyone around the world. So my brief was to talk on a tertiary center ICU response. And so I've got no disclosures for this. I'm an intensivist and a transplant surgeon. Groote Schuur means big barn. And I'm based at the University of Cape Town in South Africa. And I don't need to tell you, between intensivist and transplant surgeon, which has been the busier career option in the last 18 months. So South Africa is technically an upper middle income country, if you look at us, but unfortunately we hold the distinction of being the world's most unequal country, even after the ending of apartheid. And it very much differs whether you play golf or don't play golf as to where your healthcare resources will come from. So just to give you some sort of perspective on our denominator, we've got two healthcare systems, and 30% of the doctors are working for 84% of the population in the public healthcare system, and 70% of the doctors for 16% of the population in the private sector, with a vast discrepancy in the amount of per capita expenditure going on between the two sectors. So I'm working at Groote Schuur Hospital. It's a government-funded hospital, but even within the South African state sector and the provinces, there's big differences in healthcare outcomes. And in the Western Cape, where I am, the life expectancy is 10 years more than in some other provinces in South Africa. So COVID was really a blank slate for everyone. Unfortunately, the missingness of the data Nicole has spoken to already. And if you look at the stats, South Africa data, you can see here how the death rate goes up related to COVID waves, but the proportion of those that are actually being recorded as COVID deaths is actually quite low. And COVID's really shone a spotlight on the gaps within our data systems. And we've compiled all these dashboards, and actually, depending on where you live and who your leader is, you do have a reliance on data and the interpretation of that data by experts in order to guide your healthcare policies and your interventions and your social impacts of trying to control this virus. So we wrote up our experience on the first wave as a hospital-wide response. And it's important to say, and it was alluded to by Nicole, in terms of the time frame of things changing. So at the start of this pandemic, we took over our International Convention Center into a 1,000-bedded hospital. But by the second wave, it had been closed and we're down to a 300-bed extra hospital in a warehouse outside of Cape Town, about 50 kilometers, in terms of our dedicated extra COVID response. So where does that leave the hospital system, given that that's where the resources went to? In terms of organizing our ICU response within our hospital, there's a lot of juggling of beds that's going on and repurposing of wards and repurposing of staff from one area into another. And because our finite pot is very finite in lower middle income countries. And Groote Hospital, our baseline is 25 ICU beds in a combined service run by intensivists, 6 cardiothoracic, 8 surgical, 8 medical beds, 3 isolation ICU beds, and the 6 neurosurgical ICU beds keep separate to themselves, and the 4 spinal ICU beds are kept separate. And we serve a population of 2.5 million, and we're a 900-bed tertiary university hospital. We decline about 5 to 15 patients as good candidates for organ support in ICU each month, with no capacity to accommodate you, and this was prior to the pandemic. 2 ECMO machines, 3 CVVHD machines, 6 SLED machines, and 4 high-flow nasal oxygen was our baseline extra machinery in ICU. Ventilators were not a rate-limiting step for us. We don't mothball them fast enough, so we actually had old ventilators lying around in a capacity that dwarfed the nursing shortages that would become apparent. We're staffed with 5 intensivists, a trainee intensivist, 1 junior anaesthetist, and 5 part-time pulmonologists. And prior to the pandemic, we were using 1 ton of oxygen with 30 tons of storage on site. What was our response like? We got up to 112 ICU beds in a combined service. 4 cardiothoracics was kept out, and 6 non-COVID ICU beds were kept out of that combined service. Neurosurgery and spinal unit also remained separate. We actually commissioned 48 of those spaces for mechanically ventilated COVID patients, and the rest of the capacity was actually created at repurposed wards where high flow and high care was given, and so not full ICU level staffing response. We had no extra hospital staff, so we were managing ICU with ophthalmologists, registrars, sleeping in, and intensivists trying to supervise them. And our oxygen consumption went up to 15 tons per day, with initially 30 tons of storage, and now we're up to 45 tons of storage on site. Rostering, which was my baby, took up an awful lot of time. And then this is what it looked like for us in terms of admissions. We were up to about 25 to 26 admissions in a week. However, what happens in our setting is that there's a hard cap on the beds in terms of nursing, the ability to capacitate ICU. And here you can see where those limits are reached, and when certain spaces get commissioned, the beds get filled up, and then you're operating at that capacity the whole time. And how are you able to do that? How do you deal with all the patients who can't access ICU? This comes down to triaging, and we try to do due justice on every referral that would come to ICU. And we would score patients, and we would use this scoring system that was circulated widely in the province, but different application between different hospitals. And at some stages in the pandemic, we are admitting only red 1 patients. So if you're older than 65 with a comorbidity, you wouldn't get into ICU. COVID waves is not just about the COVID, it's about the behavioral response. And as John alluded to, we potentially don't handle our alcohol as well as Glaswegians. And it was impressive to see the effect that this would have on the healthcare system. This type of social experiment hasn't been done before, and this is Barrett Hospital on New Year's Eve. 3rd largest hospital in the world, servicing 4 million people, and there's 1 patient lying on a stretcher there. This is not the normal scene on New Year's Day in South Africa in a casualty unit. And that meant that we actually squeezed down our entire service for 2.5 million people into 6 non-COVID ICU beds at some points in the pandemic. People's health care seeking behavior also alters drastically during the pandemic. So what were our actual outcomes? If you look at our outcomes through the certain waves, in terms of ICU survival, it varied from 38%, and in this last wave, 30% survival for invasively mechanically ventilated patients, because our ICU, as we recorded this data, was purely for patients who had failed high flow in the ward. This 3rd wave, we were asked to stretch further, and I our nursing was compromised, and we also had a pan-resistant Acineta outbreak that decimated the ICU patients. So why did we respond this way? It was a hospital-level response to use high flow in the ward setting in order to capacitate servicing more patients with supplying oxygen, because this disease is primarily a disease of oxygen deficiency. And we did write this up, the team that was looking after the wards. And again, as Nicole said, it's all related to context, because for ECMO card, we're submitting the patients in ICU, but most centers would actually be considering these patients we are managing in the ward in our hospital setting in a lower middle income country as ICU level patients. And I think you would say that because the PF ratio in that study of patients on a day of high flow was 68. And it's interesting when you try and look through the literature, and John's alluded to the delays in this literature coming out, and we're trying to see whether we're doing the right thing with our management strategy. And this paper tried to look at the effective timing. And they actually had two analyses in this paper, and we wrote up a comment on this because the two analyses used either you were intubated within the first 24 hours or on arrival in ICU as one definition of being early intubation. And then the other one was to define someone who failed high flow as being a late intubation. So our entire patient cohort in our setting could jump from one definition to the other definition, just to skew someone's results in terms of a meta-analysis. What did we achieve in terms of our ECMO service and 700 COVID ICU ventilated patients? Due to nursing constraints, we managed to only get 7 patients on, 3 survivors, all 3 of them having around about 2-week runs and another month in ICU afterwards. And we had 4 deaths in that cohort. So where do we stack up? Well, if you look in the African literature in terms of this multi-center prospective observational cohort study, mortality in Africa is reported to be about 48.2% in ICU patients. And that's not limited to invasively mechanically ventilated patients. And there's a range there. And you can see in this study, one center was not even able to pulse oximetry on the patients. So I'm not sure how high level that ICU is if it's not able to offer oxygen monitoring. So it's a real range in Africa in terms of what resources are available. And I think we need to really have a lobbying voice in order to get healthcare higher on the agenda. And if you looked at the patients not admitted to ICU in this study, which looked at about 3,700 patients, there were 3,000 patients who were screened as being sick enough, but they weren't entered into the study. So we're still trying to work it out, and I'm glad Nicole's saying we're going to be working at this for another year, because we're trying to look at the factors that are associated with mortality, especially in centers where it's so reliant on trying to triage things in order to ensure the best possible outcomes. And we do a lot of number crunching, and you'll number crunch a variable. And I'm not sure that sex is a variable that we're able to change that easily. And it doesn't really inform things. And then we'll comment on the male distribution and how this disease is potentially, affecting males in a different way. But what COVID has done is tried to shine a spotlight on that. I mean, if you start looking at the basal rates in terms of gender access to ICU, you suddenly realize that there was already a pre-existing predisposition for ICUs, for example, in France, to admit male patients over female patients. So there's a bias going on with the numbers, and we need to be really careful when we interpret numbers in terms of what the denominator is and what that context is. And if you looked in that same meta-analysis and they started looking at factors that are potentially, modifiable, invasive mechanical ventilation, you suddenly realize how few studies are actually giving you that information that are going to inform clinical practice. Because age is just a number, and we rely on it, but actually age is just a number. And what is your frailty score? And how do we tease out those nuances of the information is really important for people trying to triage limited resources. So just in conclusion, thank you very much for the opportunity to participate in this. It has been a great team effort, and it just truly feels inclusive. And it's something that we really want to continue supporting. And because there's so much that we still don't know, and we've got to keep collecting the data and keep analyzing it. And we need to pick it up from that really high first wave when everyone was going to battle, as it were, and keep recording, because there's a lot more that we need to know. And we need to make sure that we factor in all our interpretations as being very context sensitive. because it's very easy to come to broad-ranging conclusions, but how we apply them at the coalface is the crux of the matter for us as clinicians. Thank you very much. Hopefully we'll paint out these canvases of more information on ICU provision. And yeah, thank you very much, Gianluigi and John. Really appreciate it.
Thank you very much, David. It's always incredible to hear from the different situation that all over the world, the many clinicians had to experience during this pandemic, particularly from Africa. We read about these grim numbers from many publications coming from Africa, but hearing directly from you is just incredible. So we do have time for one question, if possible. I wrote before one question in the chat, and please to all the attendees, if you have a question, just and you don't want to open your mic, just write this question in the chat room. David, we have been trained for decades, not just for 1 or 2 years. An intensivist that go to the ICU and become a consultant after at least 2 decades of training, okay? How do you teach critical care medicine in a week?
Yeah, it's incredibly difficult. I think we've relied a lot on WhatsApp and pictures, and there's an ability now with technology to communicate a lot more information very rapidly. So if I was on with the ophthalmologist, she would take a picture of the ventilator and have the blood gas stuck next to it because she didn't know what all the numbers were. And it was very difficult because we adapted our shift to try and prevent burnout. So we went to a shift system. We gave people off time in the week. We started to treat weekends the same as regular days because everyone was on full lockdown and not needing to go out and coordinate their lives with weekends, which balanced the staff, you know, for 24/7 provision, but it was very definitely not the best for teaching. And I think we've lost some abilities to teach because I think ICU is a skill learned by the bedside with those clinical cases right in front of you. I think the sheer volume of cases brings people up to speed relatively quickly, but people are rotating their staff out because actually the ophthalmologists didn't come to train in ICU. And they try to distribute that load amongst their total workforce. So it was a real challenge. It's a lot of one-on-one tutoring. And I do think these patients are so complex to manage in terms of trying to prevent harm with the ventilator that it's not something you can outsource to a trauma surgical consultant who may be able to run a trauma ICU, but not be able to manage these complex ARDS cases.
Thank you very much again, David, for your contribution to the consortium tonight. So moving on, the next speaker is Dr. Alvarez. And it's absolutely a pleasure to introduce Dr. Alvarez and to emphasize the collaboration that we have with the Kuwait as well within the consortium. Dr. Alvarez is a consultant in internal medicine and critical care at the Al-Amiri hospital in Kuwait. He's also the chair of the Department of Anesthesia and Critical Care Medicine and Pain Medicine and director of Kuwait extracorporeal life program. And of course, since the very beginning of the pandemic, they had to struggle on increasing and implementing many more numbers of extracorporeal membrane oxygenation in patients with COVID-19. And he's going to give us an insight about establishing a new ECL center during crisis, the COVID-19 experience.
Thank you so much, John Luigi. Thanks to the whole organizing committee and Prof. Fraser for this invitation. Good morning, good afternoon, or good evening, wherever you are. My name is Abdulrahman and I'll talk to you about our experience in establishing a new ECLS center kind of overnight with our experience in COVID-19. So I have no conflicts of interest to declare. I'll talk about how and why might you need to start a new ECLS program. What do experts recommend in this field? Would it be ideal to start this in a time of strain, and what evidence of success or failure? So to start a new program, you have to study several aspects, and I'm just going to go take you through some of these aspects. You have to study the burden of the disease you're interested in, and here specifically cardiorespiratory illness. What population would you serve? Is this a new service really needed or not? ECMO is not for every single intensive care unit.
Yes, Dr. Alvarez, sorry to interrupt. You're sharing the presenter view, not the full screen view.
Oh, sorry. Let me.
If you wanna, yeah, yeah, down there. Perfect. Yeah, thank you.
Okay. Let me go back. So ECMO is not for every critical care unit. It's an advanced therapy for ARDS or cardiogenic shock. You should examine your outcomes in the region and see what patients you're serving and what that strategy existing if you fail to wean your patients, and what your exit strategy would be. You might want to look at and explore any regional experience or expertise where these programs successful or failed, and what was the factors that were associated with that. You need to engage your stakeholders, whether from different levels, hospital staff, administration, consumers in the form of survivors of those diseases, and their caregivers or loved ones. You have to also look at opportunities of cost and how much strain this puts on your hospital, influx for beds, pressure for beds, etc. You might want to think about how your service is affected by seasonality. Is it a year-round disease that you have to service, or is it affected by a specific season and the demand increases then? Is it related to a specific pathogen that you're interested in? And is that going to add more strain with isolation procedures, etc.? And that again expands your bed capacity to accommodate for that. Your program should be comprehensive and should be patient-centered and aim for those outcomes. It should engage patients in their family decision-making and collaborate with transparency. It should have a multi-layer objective approach with specific measured outcomes so you can examine them over time. You might want to adopt the hub and spoke model that is widely talked about, where you provide 24/7 care or ECMO support in your center and have referral centers refer these patients to you. With that, you need to have a retrieval service, an active retrieval service to provide extra support as well. Maybe ideally, you should have a small core team, a core team that is understand each other and is harmonious. And then you build up after that. And you should have, maybe you should have shared interests and beliefs where you can strengthen your program from the beginning. Team build-up is vital. Simulation, sustained training, continuous education, and regular drills is essential. Furthermore, dedicated maybe ECMO rounds, departmental meetings, discussion cases, reaching out to national and international experts might be fruitful to get that program up and running. You might also want to encourage your team to explore online content and training, and maybe especially also endorsed training courses. Engaging industry is important for in-servicing, for consumables, for latest devices, so that you should think of as well. Quality assurance is essential for any up and running program. You should aim to provide high quality and sustainable service that would resort to local experience or under trained expert personnel. You should have specific quality metrics and benchmarking to examine your program continuously. This should include processes and outcomes and follow up patients long-term. And you might also want to think about your program, that it should thrive, not only survive. You might want to join an international organization like the ELSO organization and have your data entered in the registry that you can benchmark it and compare it to other programs. To maintain your program further, you have to look at your learning curve of your team. Personally, you as a leader and the rest of your team. We know that we go through different stages, but this is essential, and you can manage expectations for yourself and the rest of your team as well. There are multiple key aspects to having a successful program, and maybe one of the top ones is patient selection, and you should avoid irrational decision-making, which will make you foster optimal and mature decision-making. We know ECMO is a resource intense, but it's another life support. So you have to assure that your program will sustain with adequate selection. Burnout is real, it's underappreciated, and you should take every single step to prevent it. And we run into a lot of ethical dilemmas with our patients when they get supported or prior to support with ECMO. So these things you should be open about, discuss it in the team, and it's okay to come to different conclusions, but you should be open to these matters. Finally, you have to foster the morals of your team. You have to for them to feel a sense of belonging and culture, and feel that they are contributing to this program and improve it or make it better. There are several papers out there where leaders in the field, whether from the ELSO organization or from the ECMONet network, that they tried to put position papers initially in 2014 with the adult acute respiratory failure, and later on in 2018 with cardiac failure, where they essentially have talked about regionality of service, and that patients should be referred to high volume centers and should be discouraging opening new centers, and adopting the hub and spoke model where you refer your patients to a more comprehensive care. So looking into the literature for the real life examples, I really like this paper from the Al-Amiri group, where they've detailed their experience in establishing their center from the year 2013 to the year 2015, over 18 months. It took them to establish their ECMO center, where they hired a director, selected leads, gone under training, protocol development, and ongoing training till they started their first case after almost a year, with the investment and engagement of multiple stakeholders: respiratory therapists, perfusionists, intensivists, surgeons, nursing staff, etc. So this takes time, and it cannot be done instantaneously. When we look into COVID-19, we had this great piece of a viewpoint published earlier on by Graham McLean and Daniel Brody, where they have said that ECMO is a therapy not to be rushed to the front line, where all resources are stretched in a pandemic. But when we look at guidelines that came up initially, the sepsis survivor sepsis guidelines suggested the use of veno-venous ECMO for refractory hypoxemia if you failed with other therapies. So you should refer your patients, you should provide that for your patients, or you should refer them to an ECMO center. Furthermore, regulatory bodies like the FDA had enforcement policies earlier on encouraging the use of extracorporeal support with COVID-19. I was fortunate to be part of this ELSO writing committee for the first initial guidelines, where we've gone through several aspects of managing these patients. But the group consensus came into the conclusion that during the pandemic, COVID-19 and non-COVID-19 patients should receive ECMO in an established institution rather than opening new ones, and that to maximize the resources and the benefits. But in Kuwait, on the 3rd of March, 2020, where we had our first COVID-19 critically ill patients admitted to ICU, we were not sure what to do with this. So we had to move, myself and other colleagues, from Al-Amiri Hospital to the COVID dedicated center in Kuwait, a mega 1,200 or so bedded hospital with almost 170 ICU beds, where we needed to create a closed ICU and an ECMO center almost overnight. Unfortunately, but fortunately at the same time, this first patient that I mentioned progressed to severe ARDS. We could not, because of the lack of the development of the team, we could not provide proning for her, but we were able to successfully support her with ECMO, lasted for around 30 days, and she made a remarkable recovery. It was for the personal support from the top MOH management, Ministry of Health Management, to assure the success, and without it, we couldn't have done it. All resources were pooled to aid our success. We had trained nursing staff come from 2 local centers where they had the most experience with the VV ECMO that supports the program. Our program, we had physiotherapists, nutritionists, clinical pharmacists, and all allied health came to assure a well-functioning ICU and transition from an open concept to a closed concept. Moreover, the perseverance of the medical team and the investment in training and education made it stronger. For the sake of time, I'm just going to mention briefly here some crude numbers. In the year 2000, we had 119 patients supported with ECMO. 82 of them were COVID. In this year, up to now, we had 150 patients with 125 of them COVID. The vast majority, 80% or more, is supported with VV ECMO. We had a successful weaning from ECMO with a range between 60 and 70%, and a survival to hospital discharge between 50 and 60% across the different waves. We had a lot of media traction earlier on. This is the outline of the first 12 cases that we had that were supported with ECMO. And this is Amira Saleh, who was the first ever ICU patient who was supported with ECMO as well. Not only ECMO, but the first patient who was intubated as well, that she made a remarkable recovery. And this was an interview with her when she left home. With Ahmed Rabi' and Mohammed Azam and other colleagues from the SWAC also, we had put our data together for the first 300 patients across the SWAC ELSO organization. And we had contributed 50 patients from our center. And although there was no difference between established and new centers, we had in the new centers more percentage of patients discharged home than established ones. So that doesn't tell you much, but at least says that starting a new center, although we've got all the resources at hand, our outcomes were very favorable. It takes a village. I wouldn't have done it personally or my colleagues without the support from the whole group, whether it's physicians, doctors, nurses, pharmacists, physiotherapists, nutritionists, every single member, even orderlies and cleaners, every single member in the unit came together to make sure that our outcomes would be optimal and great. Again, I would like to thank the COVID-19 Critical Care Consortium. We've joined them very earlier on. We were initially slow in contributing to data entry, but lately we've been recognized and one of the centers worldwide that have been successful in entering data consistently. Thank you very much. I'm looking forward to inviting you all by the end of next year, hopefully, to our ECLS Congress in Kuwait. Once we have the final dates, I would share that. Thank you very much.
Abdulrahman, shukran, brother. Thank you very much. As Abdulrahman says, Kuwait, it's fascinating to watch this thing develop. Different waves come, different waves go, and centers peak and they collect data, and then they go under the hammer of clinical needs for running the unit. Kuwait, a relatively small country that few of us have visited. It's a beautiful country if anyone gets a chance to visit. But Kuwait has really led from the fore, and Abdulrahman, we say shukran to you for your leadership there. A lot of the medical students have been collecting data there, and really big data coming from Kuwait leading, but also our colleagues in Qatar have done well, and now we've got Abu Dhabi and Dubai and Saudi as well, with Alia, who's our board member, as well as change. So we maybe have time for one question for Abdulrahman, whether I see something in the chat there. So Abdulrahman from Japan, one of the questions from Takako, selection is difficult in the pandemic. What's your best strategy for the new ECMO centres? As you say, you started new centres. Have you changed your strategy for patient selection during this time?
So we've adapted our strategy throughout, and it was very strain dependent as well. So once we've peaked and we've reached our limit with the case support, when we reached 14, 15 patients on ECMO, then we had to adapt. We realized very early on that maybe age, apologies for that, but age was a big factor with COVID-19. And when we explore all the epidemiological work, we see an exponential rise with age and mortality. So we've put age as a big factor in patient selection, and that's why we had limited and we had cut off down the age gradually. But that has been adapted throughout the pandemic. Once we were less trained, we were able to be slightly a little bit more liberal. But I think it's very difficult. It's very difficult to decide these things, but these things are very adaptable. Duration of mechanical ventilation, again, was one of the very, very important aspect. So it always comes down to a group discussion. You know, we've taken it as a case-by-case basis, and we've always discussed these cases in our smaller group to determine whether this is a good strategy to go by or not.
Lovely, shukran. Abdulrahman, thanks very much for your input, for your leadership across Kuwait for the last 18 months. We greatly appreciate it. We're going to move on now. Abdulrahman, hopefully we'll stay online, inshallah, and take some questions in the chat room if required.
I'm going to pass everything to Pauline, because Pauline, she will be the discussion facilitator for the open question and answer panel. Okay, Pauline, please go ahead.
Thank you, Gianluigi. And indeed, it's my honor to be chairing this panel discussion. We're very happy we have around the world and many experts in the field has joined us across very difficult time zones. I realize it's very early in the morning in some parts of the world. So thank you, everyone. Just as a note, we will be receiving questions primarily through Q&A section. So if you have any questions you feel you would like to direct to the panel, please do type them into the chat box or the Q&A section. So without further delay, it's my pleasure to introduce our panel today. First of all, we have Professor Bob Bartlett, who needs no introduction. Everyone knows him as the father of ECMO, and he has very generously presided as chair of our consortium over the past 1.5 years. We also have Dr. Bairbre McNicholas. Yep, hi Barbara. Who's from Ireland at Galway University Hospital. She's an intensivist and a nephrologist, and I'm sure we'll benefit from her input today. We also have from the United States, Dr. Heidi Dalton, who's a leader in pediatric critical care and ECL support. And she's, she got very early this morning to be with us. Also with us is Professor Giles Peak from Florida, United States. We all know Professor Giles Peak from the Caesar trial, and he's a certified cardiothoracic surgeon and also in intensive medicine. And certainly last but not least, joining us from India, in Bangalore, is Dr. Rajavardhan and his colleague as well. I believe Dr. Shetty is joining us. They are both in critical care medicine in India. So indeed tonight we have quite a global representation in our panel, and I'm sure have a good time listening and hearing from all input and advice. So perhaps I would kickstart with the first question. This was a question that was raised earlier by our participants about the resources we have globally, whether resources that have been allocated to the pandemic would be enough or will help us pass this pandemic on the whole. Does anyone want to start first? Professor Giles speak?
Hi. So I think this is a great question, and I think Bob's introduction showed us exactly what we know. You know, the four humours was the state of the art, and everybody knew it was right. And it turns out we knew nothing. And I think that was the same in a lesser time course, looking at what we knew about this pandemic. And the ELSO guideline group said, oh, you shouldn't set up a new centre, but the the SWAC ELSO group showed that you can set up new centres perfectly safely. Resource use comes down to central funding and central planning. Abdulrahman's exposition of what was done in Kuwait shows the support of the Ministry of Health in Kuwait created a very coherent response. In South Africa, we've heard today that there is not even enough pulse oximeters. So I think that triage and resource use comes down to central support, and you need a coherent response from government and health administrators to actually decide whether you're going to have more people on high flow or more people on ventilators, or whether you have enough resources for ECMO circuits. And I think it's very difficult for clinicians on the front line to do that. And I hope that when this pandemic is over, that we will learn to plan for the next one, whatever it is.
From the country like in India, from the resources point of view, there are always a different take actually, from a private hospital perspective and from a government hospital perspective. From a government hospital perspective, it's always a neglected part in India. Actually, not much resources are allocated. For the first time when COVID was started, government consulted our intensive care society in India, ISCCM we call it. It consulted us, they asked us what are the resources which is required to improve the government services, government hospital quality and all. We're able to suggest them, they're able to implement those resources. Definitely it made a lot of impact in the government services per se. From the private hospital perspective, always we are more keen on developing ICUs and all, because there are a lot of other aspects, not only income. From the patient care perspective, there are a lot of always resources are there in the private hospital. From the government hospital, definitely it made a lot of difference. We can see a lot of ventilators. Initially, most of the government hospitals never knew ABGs. Okay, they now have an ABG machine, they have ventilators, they have HFNCs. All those resources had made a lot of difference, and we are much more prepared after this second COVID wave. First COVID wave didn't affect us that much actually. Even though we were prepared, it didn't affect us that much. But second wave, definitely it had a biggest impact. We have expanded our ICU resources. Initially, it was only 17 bed. During COVID wave, we increased to 34 bed plus 17 bed at a COVID regular ICU. It has made a lot of differences. Even auction plant has been started and all. So definitely it has made a big impact, especially in countries like India, and government is spending much more money on health resources compared to before.
I think that's one of the things that the consortium has really been helpful with, is actually raising to the rest of the world, actually, the disparities that exist across different areas. And that allows us then to hopefully plan for the future and how to fix some of those things so that care is a little bit more evenly distributed. And I see that there's a question in the chat about what's the biggest take-home lesson. And I think my biggest take-home lesson is how international collaboration has really helped inform the field and perhaps even drive care. You know, we've seen from other countries where the pandemic started, and then as it gets over, like my area of the world here in the States, you know, things that have been beneficial, things that haven't been beneficial. And I think collaborations like the COVID consortium that we have been instrumental in helping to provide enough patient data to say, oh, by the way, you know, hydroxychloroquine does nothing, or steroids seem to be helpful, or whatever. And I do think that unlike a lot of other areas of medicine where perhaps investigators are working almost in a competitive nature to try and get answers, the transparency and the collaboration that the COVID pandemic has actually brought together has been very valuable, because networking has been a big part of what we do, and sharing data very openly has been a big part of what we do, which isn't always the case, especially when you're talking about, scientific medicine.
So agree more to that. I think Bairbre also has something to say.
Yeah, so I think the situation in Ireland is that we have, a very resource scarcity when it comes to man forces and manning our ICUs. And I think the focus in Ireland has never been enough ventilators, is actually the staffing and the nursing. And I think that's an issue, and how we use this data to better train people. And, I think also to know that the data that we're getting is even across the world. So we have a situation in South Africa, as Dr. Thomson outlined, where their patients on the ward are our ICU patients in Europe. And I think if we're going to use this data very effectively, we have to have a good idea of what the baseline is in each country, so we can compare apples with apples and oranges with oranges, and actually getting more information on the pathophysiology, and then from that derive better ways, and also derive ways of understanding who's going to experience outcomes that will be favorable from an ICU, and where it's appropriate not to bring people to ICU, use data, not intuition, for those points. And I think that'll be something that will be useful coming out of this kind of consortium.
And I think we'd all love to hear from Bob as well. What do you think your greatest takeaway from the COVID pandemic has been, Bob?
Just addressing resources that you brought up has been an interesting part of it, but in most centers, the limitation is caregivers, having enough people who know how to take care of just a everyday patient, not to mention an ICU patient, certainly not an ECMO patient. So Dr. Abdulrahman described training an ophthalmologist to take care of a patient in the ICU. And what's remarkable is they were able to do it. And many hospitals have been able to do it. And we have all taken people like OR staff, for example, and they can be very good at running ICUs, and with a little extra experience and some guidance, manage critically ill patients. So the resources, we think about equipment, we think about money, we think about just having enough oxygen and so on. Those are all very important factors that we as the doctors can't control. That's going to require government and policymakers and so on, hospital administrators who are not used to giving away free care to people who need it. But the things that we can do as the physicians are to organize how to train the people that we have in the hospitals to manage these particular very sick patients. And of course, different than most of these other pandemics that I talked about, we're at least now paying a lot of attention to protecting the staff and everybody from getting infected. If you might remember back in the 2010 H1N1 flu epidemic, my memory of it is we didn't try to isolate people. We didn't even try to protect the caregivers because, oh, well, it's just the flu. And some of those people got it, of course. So it's interesting that we have put much more emphasis in trying to protect the caregivers from catching this particular virus. It'll be interesting to see as we look over what happened, how important that was. Clearly important, but remember we were having crises and people in the news were saying, I don't have enough masks, I don't have enough gowns. I kept pointing out, you have plenty of gowns, just wash them and use them again. Oh no, we have to have disposable gowns, very important. Well, it's not important. So interesting discussion about the resources, but from my point of view, it's mostly about the people.
Yeah, I think part of why maybe all the discussion about personal protection came out possibly could be contributed because when the pandemic first unfolded in this part of the world in Asia, where, you know, a type of people, Chinese people who are slightly maybe more concerned about, personal protection, having our experience from SARS back in 2003, when we did have, outbreaks in the hospital and more than a few of healthcare staffs falling sick and even, eventually died. So that might have, been overemphasized in the earlier part of the pandemic, unfortunately.
Well, it was entirely appropriate, but at least in our hospital, in our part of the world, it was a major crisis. We're running out of disposable gowns, and we don't have enough disposable hats and things like that. And I always pointed out to people, you have these COVID patients in your beds, and sadly they die. What do you do with the sheets? Well, we send them to the laundry, we use them again. All right, can't you learn from that? You could do that with your gown and other material as well.
Yes, definitely. So there's one question from Januji. So we all know the consortium started as so-called ECMO card when we initially wanted to focus the study and the research on the use of ECMO in COVID. We quickly realized as the pandemic unfolded that resources and ICU beds were just overwhelmed, and ECMO was no longer the primary or the only focus of the consortium. But after the H1N1 pandemic in 2010, the use of ECMO exponentially increased. Do you all see this as happening to the ECMO utilization after COVID, or what kind of changes are you envisioning?
I guess I'll start. Yes, I mean, I think, the H1N1 epidemic really boosted the use of ECMO, especially in the adult world, along with technology changes, which made it a lot easier and safer to apply. And I think we're seeing that with COVID too. I mean, certainly, there are lots of centers that are supporting patients that may not have before in different realms. I can tell you at our center, we are still turning patients away a lot, which is hard on the staff and hard on everybody else. But I think one of the things that the pandemic has shown, especially as hospitals got back to normal running, when you had normal cardiac surgery and elective surgeries and elective admissions and all those things, we actually ran out of beds to put COVID ECMO patients in, and staff. And while I do think, like Bob mentioned, you can train other people to help do ICU care. When you're doing ECMO care, at least in our center, originally when we had to roll ECMO out to different areas of the hospital that had never done it before, initially the outcomes were not so great in those particular areas. They got better very rapidly over months as they got trained up. But I do think that you're going to see that there is an increasing use of ECMO. I think we have to be careful about how it's applied, however, because it is something that does take some type of expertise in terms of running it. So we don't want every Tom, Dick, and Harry just putting patients on, because I think our outcomes may not be that good. But certainly, I think with a lot of the new equipment that's come along that makes it easier as well, you are going to see it continue to increase in application for a wide variety of patients. I mean, there's many pregnant women, postpartum women, those types of things that, weren't so prevalent in the literature that have been done a lot.
Perhaps Giles, would you like to speak on that as well?
I would. I think Heidi's right. I think that we are going to see more. I think that the H1N1 showed us, if you think about, we published Caesar, then the H1N1 hit, and everybody published their results from that. And we showed great outcomes in respiratory patients. And then what happens? Suddenly everyone's doing ECPR and using ECMO in the cath lab. Now, I think that just because you use it for one thing, it kind of highlights everyone's awareness. And I think Bob's comment about personnel and Heidi's about everybody doing it is absolutely right. There are many people that have the skills to put someone on ECMO. most of whom have no idea who to put on ECMO and what to do after they put them on ECMO. So I think that focusing on training and information sharing and data sharing and education is the most important thing going forwards. But I'm sure that we're going to see more and more ECMO, and it's really become a standard of care now, I think.
I think one thing that's proving difficult in preparedness for pandemics is during the rest of the time where there is not a pandemic, it takes a lot of resources to keep a unit trained and staff to be oriented and well accustomed to utilizing ECMO services. Do you see a type of approach that would be more effective in relaying this sort of information, expertise, and refreshing this experience among centers, which in non-pandemic situations might not be using ECMO that much? What are your views on that?
Well, I think that we are going to be using ECMO because I think there are people who can benefit from ECMO that don't get it because of resource implications, not because of resource implications, but because of unwillingness to refer, if you like. And so, bridge to transplant, bridge to durable mechanical support device, support for cardiac intervention in the lab, respiratory failure, patients with COPD coming in and having CO2 removal, like people would have dialysis. All of those things are going to grow slowly and steadily, and we're going to have cadres of people who are capable of doing it, who can then be repurposed in the next pandemic. So I think extracorporeal support is growing slowly and steadily, and I think the important thing is not to forget the lessons. So the lessons about PPE, as Bob points out, the lessons that actually you can wash things and use them again, those kind of things.
A good question regarding the future of ECMO, and as Pauline points out, right now we're having a scramble to train new centers and how to deal with all these patients. But when this pandemic is under control, the need for ECMO will be back to what it was before. But in fact, it was quite high before, and so it will continue. Remember that we're talking about ECMO in adult respiratory failure, and there have been a lot of patients, but there have been an equal number of patients in the registry who are adults with cardiac failure, but quite different people are managing those patients. Then the development of ECMO over the last 40 years has mostly been in pediatrics. So there are neonatal units, there are pediatric ICUs, there are especially pediatric cardiac cases for postoperative patients and so on, that they're all proceeding along, but the activity in general, of course, just continues to go up all the time. How to maintain skills is always going to be a problem, but the main answer to that is to take the sickest and the longest run and the most difficult patients, whether they're newborns or whether they're adults with COVID, they'll be concentrated in a few centers. With the adult respiratory cases like we're dealing with now, those will result in lung treatment centers that are capable of transplantation, ECMO, and prolonged ECMO support, which is getting to be a big problem in the COVID patients. They can be in the ICU for 2 or 3 or 4 months of time, and we have solutions to that, haven't done it yet. But so there will be a need for this technology. There will be a need for specialists in that area. Eventually that will disappear. We used to have dialysis centers. I'm old enough to remember when there was one dialysis center where I happened to be in Boston. Then there was another. Now we have dialysis, ho-hum, just hook it up and do it. And so, but at the time, it was very complicated technology. Some of my resident friends in internal medicine said, we think we can do dialysis for patients with chronic renal failure out of the hospital. What? Are you crazy? We're running our dialysis. Well, here we are now. Of course, it's routine around the world. So the technology will continue to move along, and it moves along in several different areas.
It's definitely wonderful to hear this piece of his history from Bob. And I eagerly await the day when we see, ECMO just running at home for patients with chronic lung or circulatory failure. I'm aware that we only have,
Since you brought that up, from my point of view, that's the most important thing in ECMO research and in ECMO practice. What we've learned in COVID, it just takes a lot longer for people to recover if they're going to recover. And so they're in the ICU for 2 or 3 or 4 months of time. And we just can't do that. It's impractical from every point of view. You might remember when VADs first came out, artificial hearts, so that a patient would get a VAD and be in the ICU until a donor became available, a year or more. So, and now we put in a VAD and send the patient home in a week. That's going to happen with ECMO, and the technology exists right now to do that. It just everyone's a little too nervous about let's just get this person out of the ICU to a step-down unit. It's going to happen soon. And those of you who run active ECMO centers, I encourage you to do it. The devices are available on the market. People just are a little worried about sending those patients out of the ICU.
I would love to see some of these pilot patients. I think we'll just use the last few minutes to take a step back and also think about a topic that's broader, applicable to the ICU community. Do we feel like all the focus on COVID over the past 2 years might have led us to perhaps divert away from some other important topics in ICU research and ICU care? And where do you think this gap lies in?
I think,
Bairbre?
I'm actually happy to start this. I think the data that, again, Dr. Thomson's presentation from South Africa was absolutely fascinating. The lack of anybody in an ICU because alcohol was banned for a short period of time reflects very much the situation in Ireland. A huge amount of our ICU admissions are related to alcohol. I think if we start looking at like a real pandemic of problems, it's that. And I think because of COVID, we've moved away from, what's filling our ICU and focused on COVID. But I think we need to get back to other public health interventions that need to be addressed and that would actually reduce suffering. Because when you think of anybody coming into the ICU, you have to remember they're suffering a lot. Their families are suffering. They're kind of on the verge of death. And if there's public health interventions like vaccines, like alcohol prevention we can be doing to improve people's quality of life and avoid ICU in the first place, we should be addressing them. And I think COVID has certainly stopped that from happening.
Are there other topics you'd like to see addressed in post-COVID research? Perhaps right now it's hard to think, out of the pandemic. For some parts of the world, mine, for example, we're still, living in very strict quarantine environment. Maybe Dr. Rajavardhan, do you have something to add? I'd love to hear from you.
Definitely, see, this entire COVID has made a lot of differences. But during the COVID times, what we had admissions is like, generally we used to get a stroke, heart attack, and all. Those patients used to, even if they do incidental check, also they used to have a COVID. So namely, they used to get admitted in COVID with an heart attack, stroke, all those issues. Okay. Post-COVID, we are seeing the same thing coming back. Most of the patients are there, but they're coming with the similar complaints, but without COVID. That's what the difference is. And we going forward, we'll have the same, what are the same patient categories they used to come, we'll have the same cases. It's not going to make much difference. Okay.
So wrap up with Giles. Yep.
So I think these are very great points, but I'd like to give us a final point perhaps of what the pandemic has given us. And going back to John's original opening statements, we've learned because of the pandemic how to collaborate and to share across international boundaries, which is really the ethos of ELSO as Bob envisioned it right back in 1989. But I think the most important thing is that this platform that we're using to have this meeting extracorporeally, so to speak, allows us to collaborate and share information and work in research groups in a way that I hope will continue after the pandemic, even though we will go back to having face-to-face meetings again. So I think it's been really good from that point of view. We've learned how to do this.
Yeah, that's wonderful parting comments. As I don't think, in any other situation would we be able to get, so many giants together, on a single day, all speaking together and sharing thoughts. And with that, I think I would thank Bob again, Barbara, Heidi, Giles, as well as Dr. Shetty and Dr. Rajavardhan for your precious time and for sharing your expertise and your wisdom with us. We'll move on to our next presentation, and I think appropriately we'll be talking about international collaboration. So it is my honor to present the next speaker, Dr. Takako Akimoto. Takako has been very active on all of our consortium calls. She is a doctor in critical care medicine based in Japan. She has a lot of interest in the ethics of ECLS as well as end-of-life care, and she's currently based in Monash doing a master's. With that, I'll pass on to you, Takako.
Thank you. Can you hear my voice all right?
Yes, we can.
Hello, I'm Takako from Japan. Thank you for the opportunity, and it would be great if you hear my presentation over a coffee or beer or chocolate. So sorry about that. I do not have any conflict of interest to disclose. So I am working as a critical care and anesthesia doctor in Sapporo, and I first joined the ECMO card project on January 26, 2020 with John's urgent email from Brisbane. Since then, I have been involved in the ECMO card project as a regional member. Today, I would like to share our experience for establishing good international collaboration such as ECMO card in the pandemic. So this is today's topic. Fewer papers were published on the coronavirus at the beginning of the pandemic. It is challenging to conduct international collaborative research at the beginning of the pandemic. This workload in medical and research fields, no existence methodology for international collaboration for political reason, and self-interested nationalism are causes of the difficulty. So my question as a regional member is, what requirements must be met in a good international collaboration? So Parker described 8 criteria for good collaborative international research. These things are really important, but seems quite difficult. Before sharing our experience, please let me explain about the COVID situation in Japan. 1.7 million people confirmed as COVID-19 and 18,000 people passed away since the pandemic starts. Nowadays, the number of patients is decreasing. We had 5 COVID waves. The deadly 5th wave of infection almost overwhelmed the medical system during the summer. At such a situation, we collaborated the ECMO card project. So working as a regional member at the beginning of the pandemic, we built the research base for requesting from ECMO card. Also, we were preparing for the research protocols in Japanese, and we recruited the collaborative hospitals. And through the pandemic, we tried to seek the way of collaborating and contributing to the ECMO community. Sharing the useful information to collaborative hospital is one of the way. In February 2020, we built the research base for ECMO card in Japan. The first challenge was its urgency due to the pandemic. We understand that the importance to build up the database for the unknown virus. The Japanese situation was chaotic because of the cruise ship outbreak, and hence we had placed members outside Japan. I was able to work with Dr. Kei Sato and Ryu Keibun, and they were able to take the lead in the process, which was very efficient. We have set up the research base in Japan, led by Professor Ichiba, and this is our team. After building the research base in Japan, we were preparing for the research protocols in Japanese. The translation process was so complex, and we worked together with members from outside Japan. However, the approval of ethics research was quite challenging. There was two main problems. First, each hospital has the different requirements for the ethics review. Therefore, the documents were required more than provided by the ECMO card headquarters. And second, IRB had not been held due to the lockdown or work at home. It took longer than usual to check the necessary documents and to get approval. I'm sure that there may be similar problems in other areas, but it was a very hectic and stressful time. From March 2020, we were starting the recruit collaborative hospitals. One of the programs in Japan is the influence of various academic organizations such as medical society and universities. In addition, there is a complex web of academic hierarchy, and even beneficial scientific research may not be allowed to be carried out on its decision without the approval of hierarchy. So they are the potential barrier to recruit the hospital. Further, we were worried about the participation in the research may increase the burden of each hospital. We had a lot of strategy meetings, but we could not reach one good solution. To what extent collaborators would be given the authorship was the critical program. This is because all contributors of research could expect attribution as authors in Japan. There was no confusion because the ECMO card head office mentioned the authorship at the early stage. However, the academic rewards may contribute to the factor in participation in research in Japan. And discrimination against medical institutions treating COVID-19 patients is also a problem. At the beginning of the pandemic, some hospitals, such as ours, did not want to disclose they treated the COVID patients. The staff and the family were discriminated against when they disclosed that they were involved in the treating COVID patients. For example, it is bullying for the medical practitioners' kids in schools, or denial of entry to shops or restaurants for medical personnel. Social stigma for COVID patients and their family was also an issue. This meant we could not recruit for the hospital on the large scale. So we were only able to recruit 27 hospitals in Japan, but we are seeking the way to contributing the collaborative hospitals. One of our activities is to curate a monthly meeting newsletter. And many doctors in Japan are very busy with teaching, research, and other duties, as well as clinical work. We are trying to report the latest medical findings from ECMO card meetings to our collaborative hospitals. Lastly, I would like to share the ideas for good collaborative research based on our experience. This is a previous 8 criteria for good collaborative research by Parker. So how can we use our experience to prepare for the better cooperative international research in the future? As a study at the Contribute to Primary Science, this COVID-19 was an appropriate and urgent topic for research. In addition, the leadership around the CCCC committee members has been very helpful, so thank you for that. To achieve competency and a commitment to good scientific practice, I think we need to establish the ethically appropriate research. In the ordinary time, it may be useful to develop research protocols and code of ethics that are required in each country. Accurate data entry is also required. In a pandemic like this, where medical resources are depleted, data entry was a burden. So like Nicole said, it is important to put the automation of data entry could be essential. Nominating regional experts who are familiar with the academic and cultural context in their country is the best way to acknowledge the respect for the regional needs. I think we can train a young generation such as me in each region at the same time, and experts from each region. So finally, cultivating the trust and confidence and justice and fairness in collaboration is the biggest challenge during the collaborative research. It is challenging to gain credibility and practice impartial research during the pandemic. This experience in Japan has shown us that it is very difficult to build the research base from start. So what we can do to earn community's trust is ongoing contributions to the region and scientific communities. So that is my presentation, and we look forward to getting your feedback. Thank you.
Thank you so much, Takako. That was fascinating. I think Japanese culture and the whole country has always fascinated me with you know, how deeply rooted in culture and history you are. And I think you rightly pointed out that it's extremely important to have regional representatives linking up together research centers in a country or a continent or a region that will really help to gain confidence and to buy in all the centers to contribute data. And we hope this amazing consortium that John and Gianluigi and Jackie and everyone has built will continue to other topics in ICU research after the pandemic. And and we do have 1 or 2 minutes for any questions. If we have them from the floor.
Can I mention something?
Of course, please do.
Sorry, we had many programs in Japan and even in the ECMO card project, but always ECMO card or other experts from all over the countries mentioned or helped a lot of me. So this society's communication was quite wonderful for me. So I would like to thank all of the experts and friends in the ECMO card. That's all from me. Thank you.
Definitely. I think every one of us who's been part of this consortium has made a lot of new friends, even though we've only met virtually. It will be wonderful, you know, once the borders reopen. I think, John, you need to call for a physical meeting for the consortium for everyone to celebrate. So I just have one question for Takako. I was interested to hear what you felt was the greatest hurdle for a country like Japan, who may not have native English as, you know, a commonplace language, to participate in an international research effort. What were the greatest challenges for you as well as for your colleagues in the country?
Thank you. That's a very good question. First, translation program is a big one, but we have a clever case at and Kevin, so it was not big program. I think the very big hurdle is a hierarchy or academic hierarchy in Japan. So I am myself is I would say younger generation, and I do not have a strong connection to other universities, like pyramid of the hierarchy. So this was quite challenging because I'm nobody, but I have to talk with the professor in the famous Japanese hospital. So that was quite big hurdle or mentally hurdle to me. So I think that would be great if there are many experts or role model in other countries or even in Japan. So these communications sound quite helpful. So, but I think the biggest hurdle is not English, but academic hierarchy or cultures.
Yeah, and I think that highlights the importance of getting regional representatives, because only people who have grown up in that country and in that culture would really know, you know, these type of subtle nuances in the research culture. We do have a question from the floor, although I'm not sure I entirely interpreted correctly. Please correct me if I don't. I think that question to Takako is whether you used any form of communication to disseminate this research data to the broader population yet? Is that something you see Japan doing in disseminating this information to the public?
Thank you for the good question. I am sorry that I do not have a good answer for that. So is it all right to answer that later on the chat or something like that?
Yeah, for sure. Yeah, and I think that's also one of the things where the dashboard might help. We earlier heard about maybe that we will have a live dashboard coming up later this year, if not early next. I think that is also one of the main aims of the consortium, to provide more lifetime, real-time data to practicing practitioners around the world.
Thank you, Pauline.
Thank you so much, Takako, again, for sharing your experience and spending time with us tonight. It's my pleasure to introduce the next speaker, Professor Antoni Torres, who's from the University of Barcelona in Spain. He's an expert in respiratory intensive care research, and I'm sure he will have a lot to share with us in terms of a COVID study from Spain. So, Professor Torres?
Yes, thank you very much, Pauline. First of all, thank you for allowing me to speak today. And I'm also very glad to belong to the ECMO CAR Consortium and a member of the steering committee. So I'm going to present this project funded by the Spanish health authorities, the government, which is called Fiberes UCI COVID, that deals with risk factors, personalized prognosis, and 1 year follow-up in patients admitted to the Spanish intensive care units for COVID-19. Well, I am the PI of this study that started May 1st, and we were very lucky because that project was funded with almost 2 million of euros, and that's the reason that we could almost finalize them. Let me see. Okay, this is the study designs. We speculated, or we calculated, that we could include 50,000 patients admitted to the ICU with COVID infections belonging to 50 Spanish ICUs, and we could obtain plasma blood samples for the studies in male patients for epigenetic and biomarker study. Another objective of the study was to perform 6 month and 1 year follow-up of the patient's discharge to determine mortality, respiratory function, and cardiovascular sequelae and quality of life. So we structured the project as a European project with several working packages that you can see here. So it was really not easy at the very beginning, but I think in that way, everything was pretty well organized. So coordination and management, ICU clinical data, follow-up data, biomarkers, statistical analysis, and writing and dissemination. You can see here at the right of the slide, the steering committee that every week still has one call via Zoom to follow up the development of the project. And this is the timeline. So the project was granted on May 2020. We launched the CRF in June 2020, and the first patient was included. In August 2020, we had the collaboration of the Spanish Society of Intensive Care, and they transferred 868 patients. And then the Hospital of Getafe in Madrid transferred 1,098 patients. Not all the patients were useful because we wanted consecutive patients admitted to the ICU. In August 2021, we completed the 5,000 patients, and in September 2021, our first paper was in press. And at the end of last summer, we also had an agreement with ECMO after very difficult discussions with the responsibles of the money and the Spanish authorities, but we could transfer the majority of the patients to the ECMO data. Hold on. Okay, these are the ICUs that were included. Of course, we had to speak individually, but all of them with the chief of the unit and the data entry person that was going to collaborate. And thanks to the money that we had, we could pay individually data entries for every single unit or for packages of patients. For example, with a package of 500 patients, we paid an amount and successively. Well, we completed now how is the study. You can see here that now currently we have more than 5,800 patients that are completed, that we call completed, and the total records of almost 8,000 patients. You can see here some baseline characteristics when we had 5,437 patients, comparing survivors to no survivors. This is not very different compared to the information that you have seen from many countries. So difference in comorbidities and in sex and in age and even in body mass index. And these are the important results, because as you look at here in this slide, you can see the flows of the population that we included, all of them in the ICU, ventilated or not. And at the very end, the total mortality of 1,684 patients was 31%, and 3,757 could be discharged from the hospital. Okay, and some of the information about the time period between the initiation of the symptoms and admission to the ICU, admission to the hospital, initiation of mechanical ventilation, and then discharge of the ICU and discharge from the hospital. As you can see, of course, the survivors had a longer time compared to the non-survivors for time to mechanical ventilation, time in the hospital, and time in the ICU. And for example, you can see here in this part of the slide that the non-survivors had 19 days of, the median was 19 days of hospitalization, while the survivors had 26 days. Well, and some of the information that we could initially publish is in critical care. You can see the information here. And we look at the evolution of the ventilatory ratio and other parameters sequentially. One important issue of our database and the data that we collected is that we obtained data sequentially on day 1, on day 3 of ICU admission, the day of extubation, the day of the discharge of the ICU, and the day of the discharge of the hospital. And as you can see here in the multivariate analysis, in part of the population that we had at that time, we could see that the delta ventilatory ratio between day 1 and day 3 was a factor of bad prognosis, and other prognosis factors that we detected were the age, we know that for sure from other publications, the delta serum creatinine, and the delta decrease in the platelet count, as you can see here. I think this is important because ventilatory ratio as a prognostic factor was not really demonstrated as it is in COVID. Is a prognostic factor well recognized in ARDS, but now in that study looking at day 1 and day 3, we could demonstrate that. Okay, another important recent publication, this is now accepted for publication in European Respiratory Journal, is some information about the people that were vaccinated with the complete schedule, 81 patients. We included in the final version 100
Professor
patients.
Torres,
Yeah.
I think we are still seeing the ventilatory ratio slide.
Okay.
We cannot see the new slide.
Okay. What now? Is okay?
It's still the same. If you want
No, because the problem is that I cannot share now. What about now?
Yes, now much better. Yeah. This is
now you can see that. Okay.
Yeah.
Thank you very much.
If you click the full screen,
I'll try.
Yeah.
Sorry about that. And then importantly, now, okay, thank you. Now this paper is published, and we compare 81 patients with 100 patients, on some of them with the fully scheduled, with the full scale of vaccination versus patients not vaccinated, admitted to the ICU and mechanically ventilated, the majority of them. You can look at the difference, more comorbidities, more immunodepression in that population. I think this is an important information. And when you look at the full mortality in the ICU was 34% versus 28.6% in the not vaccinated. Okay. Other milestones, as I said before, is the obtention of almost 100 samples of blood for the study of inflammatory markers and epigenetics. And this is a paper that we published in the Journal of Internal Medicine, and is the combination of 3 papers that tell us that the absence of low level of antibodies, IgG, IgM, specific antibodies, the presence or not of antigenemia in the plasma, using the very easy technology that you use for antigenemia in the blood, and the high viral RNA lowered, all these patients have an increased mortality. And I think this is very important to obtain samples when the patients are admitted to the ICU to look at the prognosis and for personalized treatment. Another article that we published as well very recently was that we found signatures of mRNA NAS to determine the prognosis. And this is a paper that is published in Translational Research in the first author is Gonzalo Calvo. As regards the paper of vaccination, Ana Motos is the first author, and Ana Motos and Laia Fernandez are my main helpers and the drivers of all this study called Ciberezootic. Finally, we could follow up all the patients, a lot of patients, and we have this information. I think it's important as well. This is sent to intensive care medicine, and you can see that the COVID-19 is a disease that kills patients in the acute period of the disease, a lot, very high mortality when they go to the ICU, but after discharge, the mortality is very low, 1% only in more than 4,000 patients. And this is important because this is very different compared to community acquired pneumonia that reaches a mortality of 30% at 1 year of discharge of the hospital. In conclusion, we enrolled a large population of COVID-19 ICU patients, including baseline characteristics, ICU and mechanical ventilation data, treatment complications and outcomes. The in-hospital mortality was 31%, and 75% of patients required mechanical ventilation, invasive. Ventilatory ratio is one of the prognostic factors among mechanically ventilated COVID-19 patients. Few deaths after discharge were registered at 1 year, 1%. A clinical scenario of severe COVID disease requiring ICU admission is possible amongst the vaccinated population, especially those with comorbidities and/or immunosuppression. Low anti-SARS-CoV-2 antibody levels predict mortality, and these antibodies, we know that contribute to prevent the systemic dissemination of SARS-CoV-2, and the severity of COVID impacts the circulating mRNA profile. And this information could be used as well to determine the prognosis of the patient. So thank you very much for your attention. I'll be very willing to answer the questions. And thanks again to all my collaborators, and especially Ana Motos, Laia Fernandez, and Adrián Cecato as well, that helped me a lot in this project during 1 year and a half.
Thank you so much, Professor Torres. I'll pass the stage to Gianluigi, who will take any questions from the floor.
Yes, thank you, Pauline, and thank you, Professor Torres. Thank you particularly because, as we often emphasize, the collaboration with Spain of the entire COVID-19 Critical Care Consortium has been absolutely consistent from the very beginning, and very with mutual benefits as well, because just a few days ago we had this big jump of 6,000 patients merge into our data set, and we deeply thank you and all the data collectors in Spain for that. Okay, so
thank you, Jan.
Like to, any question from the audience? Otherwise, I'm going to start with well, several questions that we have after your presentation. Okay, so let me just start about the vaccination. Okay, this data that you submitted to ERJ, these are very interesting, absolutely new data. In terms of the vaccination, did you find any specific characteristic feature associated with the type of vaccination or the number of vaccination of this patient who ended up in the ICU, although they were already vaccinated?
No, Gianluigi, be aware that we only included 100 patients, and these patients were systematically searched for in, I think, in around 10 units, not in all the ICU units in a very recent period. And there were no difference between vaccines, and the majority of them received the 2 doses of the Pfizer vaccine.
Okay, very good. And in terms of, so I do remember I worked in Spain for more than 10 years with you, and I do remember that one of the problems in Spain were smoking and respiratory comorbidities. As a pneumologist rather than intensive care physician, there's been a lot of controversy throughout from the beginning of the pandemic about association between smoking, respiratory comorbidities, and increased severity or mortality with COVID-19. What are your insight and feedback on that? And do you think we have already enough data on these topics?
Well, Laia Fernandez is managing that data for COPD patients. There was not too many COPD patients, but we know from the literature that COPD is a risk factor for worse evolution and prognosis. This is not the case of asthma, bronchiectasis, and interstitial lung disease is very difficult to study because there are very few patients. And as regards smoking, is one of the things that we are going to look to search for in our database, because the data is controversial.
Again, any question from the audience for Professor Torres?
Doc, I might just firstly echo what Gianluigi says. You've been one of our strongest supporters from the start. You've pretty much been everywhere, even when you were sick yourself. So gracias for all your help. What's, as someone that's been involved in intensive care for so many years, what do you think the one take home you've had that's been different about this pandemic from managing intensive care generally? What is the one thing that you've learned differently in this pandemic that you will take away from it that we should learn for living after the pandemic, please?
I learned several things. Even I had a slide prepared, but I do not have this slide with me. One, as Pasteur said, microorganisms will have the last word. This is very important, and this is the reality. And this is very important. The second, we did not take care, or we did well, about what happened with SARS in China. And we started with a lot of preparations with SARS, but since SARS did not come here, we forgot it.
Yep.
And second, Lombardia was very close to Spain, and I don't understand why they didn't not lock down the frontiers. We saw so many cases in Lombardia. And as regards the care of the patients and the research, I think that at the beginning, it was a mess because they were changing the protocols constantly, every day, only because a very small observational study was published. And I think that we cannot do that. We have to be very careful with this, and then even guidelines were misleading. For example, about corticosteroids, we could have saved a lot of patients. So we have to be careful. Not always guidelines are correct. And finally, as a research, very important that the governments put money on that. I think this is very important because with money, you can do more things. This is the reality. And without money paid to pay the data entry, we could not have done this project. And another thing, you have to read the literature when there is a pandemic about it happens, what is happening in other countries. And I read what was happening in China. And in that way, we could save my brother-in-law because he was on the first very sick. The chest X-ray was normal, but I ordered a CT scan and there were a lot of infiltrates. And even the radiologist said, this is a COVID in resolution. At that time, he almost died.
I think you're right. I think we didn't learn from SARS-CoV-1. We didn't learn that from Lombardy that the viruses don't care about country zones or war zones or time zones, and we have to act as a global community. And this is what I think we've done so well, and that you have led from Catalan and from Spain too. Gianluigi, over to you.
Yes, just one simple question. Is there any data set that could be comparable to the data set that you have created in Spain, or this is the largest data set from ICU patient in Spain?
No, in Spain is the larger data set, is the larger and the most complete in terms of number of variables, and I think the quality, because I was going to ask this morning when you started the session, what about the problems of the data sets? And there are the missings, the discordances, and the outliers. This is a problem. We need to prepare the health systems about having automatic recording. This is very important because it's a pain in the neck to record manually all this data.
Yeah, we are absolutely on the same page, and this is, I think, it's one of the biggest vision of Professor Fraser as well, that we are trying to create an automatization of the entire process, because particularly in the middle of the biggest healthcare crisis that we face in the last 100 years, it was absolutely inconceivable to think that any healthcare provider could spend some time collecting data manually.
Exactly.
I think it's time to just turn the page and to create an automatization of the entire process, particularly from the ICU, because ICU in all these major SARS outbreak have been the main focus of attention and the real core of patient that could die.
Yes, yes, John.
Yes,
yeah. Just one thing. I want to tell you that I am very proud to belong to this consortium and to belong to the steering committee.
We're very happy to have you, Doc.
Yeah, I'm going to pass it to John. I think for the sake of time, so we're going to have a little bit more time for, if you want to introduce Bairbre for the next abstract presentation.
Lovely, thanks. I'm going to be the very poor fill-in for Bairbre. Dr. Torres, thank you very much. Barbara's got a whole pile of things. Firstly, congrats to Bairbre for her own work on the prone positioning in the spontaneous breathing. It's been very well covered, as it should be, in the lay media as well. So we're going to move on to the abstract competition. A key thing that we've said, excuse me, that throughout this is we're trying to create a group of young leaders. It shouldn't all be boring middle-aged men and some ladies too. And this is what I think we've created. So we're going to go through the abstracts. We've got an extra late add-on, but we're going to lead from Keisato from Japan. It's 3 minutes. We will be fairly brutal. So please try and finish your talk within 3 minutes. And Bairbre is going to run the abstract competition with me talking nonsense at the sides.
Yeah, so they're going to run their slides. But yeah.
Good. Keisato, your slides are all yours. Thank you.
Hello, can you hear me?
Yes, thank you.
Perfect. So is it better to run the slide by myself?
I think so, yep.
Okay, I will share screen. Just a moment. Can you see my screen?
Indeed, yep.
Okay, so all right. Thank you very much for having me. It's a great opportunity for me to present our cardiac sub-study research. So I'm Keisato on behalf of the COVID-19 Critical Care Consortium and Cardiac Sub-Study Group members. I would like to talk about the association between renin-angiotensin aldosterone system inhibition and in-hospital mortality in critically ill COVID-19 patients with pre-existing hypertension. There is no conflict of interest related to this presentation. The influence of renin-angiotensin-aldosterone system, RAS inhibitors, on the critically ill COVID-19 patients with pre-existing hypertension remains uncertain. This study examined the impact of previous use of angiotensin converting enzyme inhibitors, ACE inhibitor, and angiotensin receptor blockers, ARB, on the critically ill COVID-19 patients. This is a prospective observational cohort study. A cohort of critically ill COVID-19 patients with pre-existing hypertension were included. ACE-ARB group and non-ACE-ARB group are compared. Outcomes are in hospital mortality and hospital length of stay up to 90 days following ICU admission. Among about 1,200 COVID-19 patients with hypertension, 746 patients were divided into two groups, ACE-ARB group and non-ACE-ARB group. In terms of the baseline characteristics on admission, most of the features are similar between two groups. There are two main results. Previous use of ACE-ARB was associated with decreased in-hospital death and longer hospital stay. Figure 2 shows significant lower mortality in ACE-ARB group, and Figure 3 shows reduced hazard rate of in-hospital death in ACE-ARB group. There are two main discussion points. The lower mortality in ACE-ARB group could be associated with vasodilatory and anti-inflammatory effects of angiotensin 1.7 and 1.9, which was increased by ACE-ARB. A longer length of hospital stay in ACE-ARB group may be because patients who are discharged alive tended to stay longer than those who died during admission. In conclusion, in critically ill COVID-19 patients with pre-existing hypertension, the use of ACE-ARB prior to ICU admission was associated with a reduced risk of in-hospital mortality and a longer length of hospital stay. Thank you very much.
Domo arigato, Keisato. Thank you very much. Wonderful presentation, great work, and great leadership by yourself and Rakesh as well. Okay, it's a rapid fire. We're going to move next from Japan to Hong Kong, and our good friend and colleague, Pauline. Pauline's going to speak now for 3 minutes on geographical differences, patient characteristics, and ICU management on COVID-19. Thanks, Pauline.
Thanks, John. Thank you for the opportunity to present. And before I start, I need to say this is really not my study. It's data from the consortium, and we're just stakeholders. And I owe a lot of thanks to Heidi, Nicole, James, as well as the whole consortium for coming up with this. So in this study, we basically included most of patients who are in the data set, and we tried to examine geographical differences between patient characteristics in different parts of the world. We included a total of 6,300 patients. We had roughly 3,000 patients from Europe, 1,000 each from North America and from Europe. We had about 600 from Latin America, and then 187 from Africa and 80 from Australia. So this graphic representation shows the enrollment or patient admission to the ICU over time, beginning from January 2020, or when the pandemic just started. So as you can see, most of patient enrollment came from Europe in green and North America in blue in the earlier part of 2020 during the first wave of the pandemic. And in subsequent iterations of this project, we look forward to including data, for example, from Professor Torres' Spanish database as we redo the analysis. So we were interested in identifying or examining how ill patients were. And as you can see, graphed here on the left is the incidence of invasive mechanical ventilation in terms of days since hospital admission, and in days since ICU admission on the right. I think the most evident thing was there were some parts of the world, Africa, for example, if you look at the graph on the right, where the rates of invasive mechanical ventilation reached almost a staggering 100% within a few days of ICU admission. And this is in contrast to, for example, in light blue, Australia, and the other end of the spectrum where the rates of invasive mechanical ventilation stayed at around 40%. There were also hints that there were significant differences in the severity of illness of patients across different geographical regions. So this is the PF ratio of patients within the first 24 hours of invasive mechanical ventilation. And there is a sign that it's lower, for example, in the African and in the Asian cohorts compared to the rest of the world. Similarly, I think we were seeing lower oxygen saturations and higher heart rates that were probably also indicative of the severity of respiratory failure in these parts of the world. As regards to outcome, these are crude mortality ratios. In gray, the percentage of the admitted patients who died after ICU admission. Again, not to isolate certain parts of the world, but we're seeing the greatest disparities amongst, for example, Africa, where the cumulative probability of death at 28 days reached up to around 60%. And this is in contrast to less than 10% in Australia and New Zealand. So again, this is really your data. We believe we truly have a very special data set in the COVID Critical Consortium. This is a representation of all the selfless and the contribution from all data collectors across the world. And with that, thank you very much.
Pauline, thanks again. Just to be clear, we're going to be judging these through the week. We've got a number of judges that will be jumping in and out, so they'll be looking at the videos through the week. So these will be announced through the week, just when they've had time to look at it. So thank you for that, Hala. We're now going to move from Hong Kong to Kuwait, the wonders of modern technology. We're going to move to Hala Hamada from our colleagues in Kuwait and listen to her. So shukran, Hala, and the slides are all yours.
Hello, everyone. Can you hear me?
We can, yeah.
Okay. So hello, everyone. Thank you for joining me. I'm Hala Hamada, and today I'll be discussing to you guys our experience from Kuwait's National COVID Center, mainly about the obstetric and neonatal outcomes of critically ill pregnant women with COVID-19. So there's no conflict of interest to declare. So what we saw is that in the third wave of the pandemic, we saw an increased incidence of critically ill pregnant patients being admitted to the ICU. And we wanted to look at the impact of the maternal and fetal outcomes because we were unsure at that time of the outcomes of that time. So this is the COVID hospital, the designated COVID hospital in Kuwait, and it's called Bairbre Hospital. So what we did was we looked at a retrospective chart review. We looked at all pregnant women who tested positive for SARS-CoV-2 and were admitted to the ICU from the months of April 5th to September 4th. And we looked at baseline characteristics, the type of oxygen therapy used, and the maternal and fetal outcomes. So we had about 922 patients admitted to us in the ICU. 408 were female, and out of the 408, there was 87 who were pregnant. So just looking at the baseline characteristics, about the age was about 34 for most of the patients, the median age. The BMI was around 31.5, and we had a gestational age of 29 weeks. Most of the patients were previously healthy, but the most common comorbidity was diabetes at 13%. And we also had patients that were hypertensive, hypothyroid, and asthmatic. So the type of oxygen therapy used, we looked at, we found that 12 patients required low flow oxygen, meaning 15 liters or less. 25 patients were on high flow oxygen, and 50 patients were put on mechanical ventilator. Out of the 50 patients, 28 required to be placed on ECMO. We didn't have any patients that were put on BiPAP. So what we found was the mean day spent on mechanical ventilator was 22 days, and the mean duration of ECMO was 27 days. This was similar to our non-pregnant ECMO run, which was about 31 days. That's what we saw for our ICUs. And in this picture, you can see one of our longest standing patients. She was on ECMO for about 3 months, and she was out to get some bit of Kuwait sun. So our maternal outcomes, we found a mortality rate of about 11%. 10 patients died. All of the 10 patients were on mechanical ventilator, and 9 out of these 10 patients were also on ECMO. One of the patients who was on ECMO died from an ICH, and another died from myocarditis. So it wasn't necessarily RESP issues that caused the death. And as for neonatal outcomes, we had 25 patients that were discharged home with viable pregnancies. We had 53 newborns who survived and 12 who died. The 12 newborns who died, we had 10 spontaneous abortions in the ICU, and 2 died during the neonatal period. So we had one newborn who died a few days after, and then another who died 2 weeks after. So in conclusion, what we found was like it was generally favorable outcomes, but I think we needed to understand more what are the factors that are causing this generally favorable outcome, and something we wouldn't have expected to see. Thank you.
Shukran Hala, fantastic presentation. As I say, our colleagues in Kuwait have done tremendously well. We will move on in terms of timing. We're going to move from Kuwait, so we've gone from Hong Kong to Kuwait. Now we're going to Dr. Mika Tambobundan, who's come from Sarjito Hospital in Indonesia. I apologize if I've got that wrong. I'm Glaswegian, so please forgive me. But terima kasih to Indonesia. They've been great contributors. And to Dr. Tambulon, thank you and take over. Thank you.
Thank you. Can you hear my voice clearly?
Yes, we can.
Okay, so good morning, good afternoon, good evening, professors and doctors. I'd like first of all to thank the organizer of this meeting for accepting my paper so I can present my research today. So my name is Mika Tampobolon. I am a pediatric resident of Universitas Gadjah Mada, Sarjito Hospital, Indonesia. So in this presentation, I'd like to report on research we conduct. The title is Factors Predicting Mortality Among Children with COVID-19 in Pediatric Intensive Care Unit. This is a retrospective cohort study in tertiary referral hospital in Yogyakarta, Indonesia. So in this slide, I want to give you a perspective on how the condition of COVID-19 in Indonesia last September. Indonesia is still the leading country in Southeast Asia in both infection cases and also the death cases. And we can see here that on the last June and July, Indonesia battles devastating second wave of COVID-19 outbreak. This spike in cases resulted in the scarcity of ICU rooms and also the oxygen shortage. This implies that a hospital needs to determine which patients are the priority to be admitted to the ICU. And from this slide, I'd like to point out that children are also affected by this COVID outbreak with in Indonesia, with a fairly high cases fatality rate, given the number 1.4%, just slightly below the global case fatality rate. On the other hand, the data on critically ill children with COVID-19 is still limited. So based on this background, we aim to explore the predictor factors for mortality in children. So this is a retrospective cohort study. We enroll children aged 0 to 18 years with confirmed COVID-19 by PCR who were consecutively admitted to PICU, Dr. Sarjito General Hospital, Yogyakarta, from March 10, 2020. This is the first date of cases we have in our hospital to September 30, 2021. So we did the bivariate analysis. Then we did the logistic regression to identify the factors that independently associated with mortality. So from this figure, I'd like to point out that our hospital is a referral hospital in a region with a very high number of COVID cases among other regions in Indonesia. So this is the results. there are 159 children with positive COVID-19 admitted to our hospital, and the total of 50 children, or 31.4%, admitted to pediatric ICU. And from the 50 patients, there are 13 patients, or 26% of the non-survivor patient. The median age was 4.8 years old, and the length of stay was 9 days. There were no significant difference between median age, between length of stay, and sex for between survivors and the non-survivors. So on this slide, we can see that there were no significant difference between survivors and non-survivors in presenting symptoms when patient admitted at pediatric ICU. From the comorbidity variable, we can see that all the non-survivor patient had at least one comorbidity, and neurological disease as a comorbidity was a significant factor to death in bivariate analysis. Based on the clinical signs, we conclude that presenting shock and also the pelot to score more than 10 were significant factor for death in children in bivariate analysis. And from the early oxygenation therapy as a variable, we found that from all of our patients, most of them, 66% given nasal cannula, then 18% given rebreathing mask or non-rebreathing mask, 10% given mechanical ventilation, and a small number given high flow nasal cannula. And from this variable, we see that nasal cannula, rebreathing mask or non-rebreathing mask, and mechanical ventilation were the significant factors to death in mortality in children. From the pharmacotherapy, the use of vasopressor was the significant factors to death in children. So from the bivariate analysis, we identified 5 covariates as a candidate for the multivariate regression analysis, including neurological disease as comorbidity, presenting shock at admission, early oxygenation therapy, use of vasopressor, and pelot to score more than 10. From this multivariate regression analysis, we found that non-rebreathing mask or rebreathing mask are as early oxygenation therapy and pelot to score more than 10 were significantly associated with COVID-19 mortality in children. So in conclusion, it is believed that pelot to score more than 10 and early oxygenation by non-rebreathing or rebreathing mask were independent predictors for mortality in critically ill children with COVID-19 in pediatric ICU. Based on the figures we had, this study can be the basis for the development of clinical prediction models for mortality in children admitted to ICU. So we can educating and evaluating the value of novel interventions, also the policies in PICU. That's all. Thank you for your attention, and now I'll be happy to answer any questions you have. Terima kasih.
Terima kasih, sama-sama, Mika. So we will move on. So I guess this summarizes what it's been like on the consortium. We've gone from Japan, Hong Kong, Kuwait, Indonesia, and we now move to Palm Springs to hear from Michael Talala, who's going to speak to us next. So Michael, we will pass over the slides to you, and I think that's about our 6th continent in 20 minutes. Thanks, Michael.
Thank you so much. It's a pleasure to make a presentation. I'll be running my own slides here. Special thanks to Heidi, Dalton, who invited me to participate. Let me share my screen with you. And all right. So today we are presenting a case of plasmapheresis with human donor plasma in the patient with COVID-19 pneumonia. Understanding, of course, that in COVID-19 cases, we are dealing with a crucial vascular insult. And the idea is that the articulating circulating cytokines and other mediators by various blood purification techniques would ultimately be a good adjunct in cases of COVID-19 pneumonia.
Hey, Michael, we can't see your slides, Michael. I think you unshared your screen.
Okay, well, let me switch. Let me switch to PDF format, if I may.
We had them at the start, Michael.
Okay, very well. So today we're presenting.
We still don't have them. We still don't have them, Michael.
Can you see the slides now?
Nope.
I think you were sharing your screen and you hit a button and now you're unshared. So just hit the share screen again.
How about this?
Not yet.
Are the slides visible now?
No, but you've got a lovely smile. There you go. There you go. There you go.
Oh wait, this is better. All right, very well, very well. So today we're presenting all the plasma human donor plasma, which was done in a 57-year-old patient admitted to our ICU in severe respiratory distress.
You're echoing. You must have two devices on at once. Or two audios on.
I am gonna turn off. Is this better? Is this better?
No. Try now. Try now.
All right. So our 57-year-old patient was admitted to the ICU with severe respiratory distress, diagnosed with COVID-19 pneumonia. She met the criteria of the clinical study we ran at our hospital, which included the use of plasmapheresis and measurement of circulating cytokines in patients with COVID-19. And I would like to point your attention to the chest radiogram on the bottom portion of the slide. Patient met the criteria, gave the consent, was enrolled in the clinical study, and we did three plasma sessions on her with quite remarkable results. If I may ask you to look on the bottom part of the screen, please look at the chest radiograms prior to the treatment and within 24, 48, 96 hours. Very significant improvement in a very short period of time, which was also confirmed by the measurements of C-reactive protein, interleukin 6, and NLDH. If you look in the upper right-hand part of the screen, you can see that the CT of the chest actually confirmed what we saw on the chest X-ray. So in our estimate, plasmapheresis with pure human plasma is a very useful adjunct in cases of patients severe COVID-19 pneumonia. We did not have a technical capability of doing an ECMO on that particular patient. Our next step would be to combine plasmapheresis and ECMO treatment at some point. Ultimately, plasmapheresis treatment with transfusion with human plasma followed by convalescent plasma is a very viable treatment modality for COVID-19 patients. Bottom line is human plasmapheresis works, and we would like to combine it with the ECMO treatment at later point. I would answer any questions if there are.
Please. Thanks for that, Michael. It was still had the. In fact, I've now got it. The echo. Are there any? We might duck away from these just now, Michael. The questions just now, because we've got one additional. The question room's open there at the side. If we are struggling with these echoes, if you are struggling, please let us know. Bob's pointed out if you turn off the speaker on your computer, but I don't think we've had too many problems with it just now. So we're going to move on to our last call, Chris Lowe, who's going to give us a meta-analysis on ivermectin. We had a fair bit of discussion with it, and the team from Singapore have tidied this up really nicely. It's a nice, well-written abstract, and within the abstract, I'd like to acknowledge the fact that they are using some data from non-peer-reviewed preprints as well. That being said, these are important data, and I think it's worth listening to. We're also going to hear, obviously, from Al Nicole later on, who's doing some work with the remap cap on ivermectin. So with that, we'd like to say sheshe to Christopher Lowe, who's going to present on his ivermectin with coronavirus 2019 meta-analysis of randomized controlled with trial sequential analysis, bearing in mind that some of these are from preprints. Chris, thank you.
Okay, hi, can everyone hear me?
Perfectly.
All right, so hi, my name is Christopher, and today I'll be sharing about the use of ivermectin in patients with coronavirus disease 2019. And as I'm sure as everyone in this conference is aware, the use of ivermectin in COVID-19 has resulted in waves of controversies, including many study retractions. Thus, the usefulness of ivermectin in COVID-19 is unclear and is perpetuated by equivocal evidence between existing studies. With that in mind, it was within this context that our group decided to conduct a systematic review and meta-analysis of existing data, given that systematic reviews are at the top of the evidence-based medicine pyramid. We then incorporated trial sequential analysis to add further value. So how do we go about doing this? We searched the Medline, Embase, Cochrane, Scopus, COVID-NMA, and MedRxiv databases for studies that reported on ivermectin in patients with COVID-19 up until the date of 1st September 2021. Our main outcome was time to recovery, which was assessed in terms of time to symptom resolution or time to negative PCR, depending on whatever the paper utilized as their outcome. Following this meta-analysis, the added value to our study lies in its trial sequential analysis. We chose to do a TSA due to its ability to evaluate the cumulative pooled effect in relation to information size for these selected outcomes, synthesizing data from all the RCTs into a cumulative outcome. The risk of bias was analyzed by the Cochrane Risk of Bias 2 tool using the GRADE approach. This was all done independently by 3 authors to ensure that we had a fair assessment of the quality of the studies that we included in our meta-analysis. So overall, we included 23 retrospective observational studies with 3,087 patients in the meta-analysis, and notably, we excluded the 2 recently retracted studies on ivermectin by Al-Ghazar and Samaha. For our main primary outcome, reduction in time to recovery, ivermectin reduced overall time to recovery with a HSG value of -0.65. Sensitivity analysis that we did, which excluded preprint studies, also found a similar benefit, which suggests that the benefit exists even if we take out the preprint studies that was mentioned earlier. Our secondary outcomes included in-hospital mortality, hospital length of stay, and the proportion of negative PCR. A significant reduction in in-hospital mortality was noted. However, there was no significant difference in hospital length of stay or in the final proportion of patients with negative PCR. Our trial sequential analysis was based on the RCTs that reported on time to recovery and mortality, the 2 outcomes that saw significant results. Ivermectin was able to pass the threshold for beneficence in reducing time to recovery. However, with regards to mortality, ivermectin was not able to pass the threshold for benefit, but notably also did not pass the threshold for harm. So our TSA shows a trend towards beneficence in terms of time to recovery, but it is equivocal in its effect on mortality. However, it's important that, as you can note on our diagram, futility analysis reveals that ivermectin was also not futile in reducing mortality in COVID-19 because it doesn't cross the boundaries for futility. So in summary, there are some strengths of our study that might be highlighted here. Firstly, the main value lies in the strength of the TSA, which provides a cumulative outcome for all studies. Secondly, we managed to collect a wide range of studies globally. And finally, we have a fairly large sample size that's one of the largest of all meta-analyses conducted on ivermectin at the time of writing. Some limitations include highly variable risk of bias and also a wide range of heterogeneity in the reported outcomes between the studies. So in conclusion, as things stand, there's a trend towards beneficence in reducing time to recovery, but equivocal results regarding mortality. Therefore, we eagerly await the results from other large-scale RCTs taking place, such as the Oxford Principle, Canada Together, and REMAP CAP trials to improve our understanding on ivermectin. That will be all. Thank you.
Thank you very much for that. It's a huge area of interest, and there's a lot of discussion about that too. We're going to move on. I see there's some questions there in the chat room as required. So, I think the fact we moved through about 7 or 8 different countries there speaks volumes of what we're doing. We're going to move away from the abstracts now and hear some more of the longer talks from some of our colleagues. Delighted to see Pete Barrett is joining us from Atlanta. in Georgia. He's been doing crit care there for over 30 years, is a world-renowned name, and we're delighted that Pete is joining us from Piedmont and is going to talk us about pregnancy, ECMO and COVID-19. He's been a strong supporter of the group from the kickoff. Peter, thanks for your camaraderie during this time, and please take away the conversation. Thank you. We don't have your audio yet, Pete.
Hello?
Yep, got you now.
Okay, thank you. I just want to say thank you for this opportunity to present our data. And so this is regarding pregnancy and COVID-19 and ECMO. And as the title says, it can be done safely if you dare. In the ELSO registry, I was not able to find very much in the way of a linkage to pregnancy. This is from the ELSO website as of last night. There's about 6,800 ECMO runs in North America, but I really couldn't find much data on pregnancy. And pregnancy, up until about 2016, a review here by Dr. Diedel and his group showed there were only about 45 patients reported in the literature that had been supported by ECMO on that were pregnant. And this is their data, and they had about a 75% survival rate at 30 days for the mom and about 74% at 1 year. But again, it's a small number with an N of 45. A more recent update by Dr. Half shows that they have about 358 women that they identified with ECMO support and data on 68 fetal outcomes. The most common maternal complication, as you could imagine, would be bleeding, requiring surgical intervention and intracranial neurologic events. And as you all know, review of the ELSO database shows about a 5 to 7% of spontaneous intracranial hemorrhage in ECMO COVID patients. Potential indications for ECMO support in pregnancy, we've adopted that they would be the same as generalized ECMO support, that is a PF ratio less than 100. We have avoided prolonged intubation times if possible, but again, compounded morally, there's a obligation to still probably go ahead if you think this is still something that makes sense. As you all know, VV ECMO is drained from the vein and returned to the right atrium. And so this was an early case reported in the British Medical Journal out of Dubai Hospital. This was a 29-year-old female who spent 5 days on ECMO support. She was at 26 weeks, got her off ECMO, and she went on to have a normal delivery. This is a case report from 9 centers across North America in the American Society of Artificial Internal Organs earlier this year. This was out of Baylor, Methodist Hospital, Tufts Medical Center, Columbia, and a couple of other centers. And out of all these centers, they only had 9 pregnant or peripartum women with COVID that were supported with ECMO. They reported 100% survival and no major complications. So I'd like to present our data. Piedmont Atlanta Hospital is a 528-bed non-teaching quaternary hospital. It's the hub of an 18-hospital system here in the state of Georgia in the USA. And from January 2020 till November 18, 21, we've supported 7 pregnant women with PCR positive COVID-19 in full-blown ARDS. Ages range from 22 to 41, and all were unvaccinated. We've had a large problem in the Southeast United States with uptake of the vaccine, and all these ladies were unvaccinated. Average time to intubation prior to ECMO support was 3.5 days. You'll see it says 1 day here. I went just the other night and got our 22-year-old, so that's why that seems so short. All patients had received remdesivir, Decadron, azithromycin, and low molecular weight heparin. My personal bias is that they were inadequately anticoagulated with low molecular weight heparin at the time of this. Average duration for ECMO support was 26 days. We have gone up to 54. All were groin cannulations in VV configuration. 6 out of the 7 had emergent urgent C-sections, and 6 out of the 7 were also percutaneously trached. 6 out of 7 survived a hospital discharge. We had one lady while exercising on the vent and ECMO support through a PE, prompted an emergent C-section, and she developed a subarachnoid hemorrhage and subsequently succumbed. So we have a mortality rate of about 14% and a survival rate of 85.3%. However, all children are neurologically intact and have been discharged successfully from the neonatal ICU to home. I'd like to, unlike the literature, 4 out of our 7 were in the first or early second trimester. Almost all patients in the literature heretofore that I can find have been third trimester. The big home takeaway here is if you are in the first trimester, you do what you have to do. And if there's a spontaneous stillbirth or fetal demise, you've done what you could do. The gray area is in the second trimester. The success rate of fetal-maternal medicine getting a premature infant through this, at our institution, we aim for weeks 28 to 29. If we can get them there, they have about an 85 to 87% likelihood of surviving their NICU stay with normal lungs and neurologically intact. So the gray area is getting someone supported from up to weeks 28, 29. And our one patient in that category, we inherited her or cannulated her at week 19, and we got her off ECMO at week 30. So you have to be in for a long haul and full dedication. Quickly, this is a 36-year-old unvaccinated lady from Guatemala who had been short of breath for about 2 weeks. She was intubated on 9/19. I went for a remote ECMO cannulation and retrieved her at an outside hospital on the 20th, brought her back to our facility. This is her echo from the 21st, which shows RV dilatation, small LV, and a CVP of 30. We put her on inhaled nitric oxide. She was on heparin and VV ECMO support. This is her x-ray. There's hope that there's lungs in there somewhere, but you know it's going to be a long haul here. This, I'm sorry, is not terribly large, but it just shows the VV configuration, draining from the left side, returning to the right atrium on the right side. You can see the fetal spine along the left iliac crest down there. So our echo people read the EF as being underfilled and the RV severely dilated, moderately dysfunctional. All these people immediately get bronchoscopies despite the risk of potential aerosolization. We've found, particularly with the Delta, that all of our patients are getting nasty secondary bacterial infections. And certainly this lady came to us with Pseudomonas and Enterobacter in her BAL. She developed signs of sepsis and low-grade DIC at about week 28, 29. All anticoagulation was stopped, and unfortunately, she developed HIT. We've also noticed an increased incidence of HIT in these COVID patients. So we resuscitated her and took her for an urgent C-section. Immediately post-operatively, she was in hemorrhagic shock. I had to convince our people to get her back to the operating room. They said they did what they could do. I said, no, we can do more. We went back to the operating room and she had a hemoperitoneum of about 2 liters. So we stopped some surgical bleeding, packed her open and brought her back to the unit. We volume resuscitated her, and as you can imagine, her lungs did not like that. But we got her through that. 5 days later, we took her back to the operating room, closed her abdomen, and we're really aggressive with CRRT and removing volume at that point in time. I felt uncomfortable leaving her without any anticoagulation because this is a lady who'd been bedridden now for multiple weeks and had groin cannulas. And so we started her back on some low-dose heparin, and you guessed it, she bled. That is not ascites in there, which is what my surgical colleagues were telling me it was. And I said, no, that's blood. They said it can't be. Did a paracentesis and withdrew 5 liters of blood. Could not get them to take her back to the operating room. They said they've done what they can do. So we drained her out, got her abdominal compartment pressure down from 27 to 12, and resuscitated her. When your abdomen is even larger postpartum than when you were gravid, something's wrong. So we hung in there, volume resuscitated her, and you can see the next problem there in the second slide over. There's a clot in her IVC, and her iliac is full of clot as well. So took her down to IR, and I put a IVC filter in her, and we finally got her through all of this. As you can see, her lungs didn't like it, but with persistence, she is now off of the ventilator. Her trach tube is out. She's off ECMO support. This is her renal function this morning. She's off CRRT. Her BUN is normal. Her creatinine is normal. She is going to lose several toes because she was on high-dose vasopressors, but she is about to go do inpatient rehab, and her baby is normal and is at home. So this is her current X-ray, a little right upper lobe scarring, but her trach tube is out. She's not on oxygen, and she's doing well. So if you embark on this, it can be done. You're going to get a lot of pushback from multiple teams. You're probably going to have to sedate your OB hospitalist and your fetal maternal medicine specialist when they see an ECMO circuit, but it can be done. And I thank you for your time.
Peter, thanks. As you say, it always seems impossible until you can do it. And congratulations to you. You know, these are 2 patients, not 1 patient that you're saving in a very, very high difficult area. We're going to move on. Time is pressing. We're doing pretty well, actually. Surprisingly, it's midnight here in Brizzy. We're going to move on to a friend and colleague, Alistair Nicole. Alistair used to bounce between Melbourne and Dublin. His bouncing has been diminished somewhat, but his output has not. He's been part of our steering committee here since kickoff, as well as being part of the remap cap. We heard one of the earlier abstracts, there's numerous abstracts of ivermectin. Alistair's involved in remap cap and works between ourselves and remap cap, and he's going to talk to us about different trials that's happening across different studies and how we're moving things. So I might just ask you, Pete, Barrett, if you can stop sharing your slides or stop sharing your screen, and then we'll pass that over to Alistair, please.
Hi, John. Thanks a million for the invite. I'll just talk for a second while we're switching these over. Thanks a million for the invite today. Delighted. And obviously, thanks for your leadership over the last 18 or so months in this consortium. It's been pretty remarkable what's been achieved. And one of the things I can sort of maybe talk to the group about today is, well, you know, some of the trials, in particular the remap cap adaptive trial, but also where this would lead for potential collaboration between this consortium and other groups that have been working in the COVID space. All right, perfect. Well, look, and again, just to say thanks again. And what I'm going to talk about today is adaptive platform trials, COVID and beyond, and talk principally about the remap cap trial, and give people a little look under the hood of some of the design features of an adaptive platform trial and how it works, some of the benefits it might have, and some of the questions it has answered for good and for bad. and how that helps inform practice, and how, as a group, our consortium may interact with Remap CAP in the future, or other platform trials. Some disclosures: I've received funding from a number of governmental bodies to do pandemic related research, and a consultancy from the University of Oxford for a Horizon 2020 project on GloPID-R. But actually, probably the biggest disclosure is actually the work I'm going to present today on Remap CAP has been the work of countless people, in particular Steve Webb, Derek Angus, and Scott Barry. And really, the Remap CAP project started with really back after the H1N1 pandemic, and a grant application to the EU back in 2013. So a lot of these ideas have taken many years to come together, and actually many, many years to put in place. And when COVID arrived, it was the opportunity to see if that preparation had paid off. And if I can bring it, so this is a slide from the Prepare, which is the EU-funded arm of Remap CAP in Europe. And back after H1N1, we realized we didn't get our act together. The public health response came in quickly, the preclinical response happened quickly, but the clinical response really lagged behind. And we completely missed the boat in H1N1. Actually, many places missed the boat for observational studies, and John and the consortium here deserve great credit for pulling everything together quickly enough. But where we aimed to get to was here, so that the clinical research response, so in particular we were interested in interventional trials, could happen at the start. And look, not to go into a lot of detail, but there's a lot of problems about starting a clinical trial in the face of a pandemic. Everything's hard in a pandemic, hard to get protocols together, get them approved, particularly if you're using drugs, and in Europe, the regulated trials, there's a huge amount of additional bureaucracy, the resources, the time, the geography, it's all very difficult. So it's always easier, as Gianluigi was pointing out, if you start earlier or start before. So if you looked at the traditional RCT, it's what we use in ICU to gather evidence. Well, you serial test a single hypothesis. So CAP stands for community acquired pneumonia. So if you're looking at antibiotics, you pick 3 antibiotics, you do a trial, you'd recruit, you'd wait, you'd recruit, you get your answer. And then you go and answer another question. Well, hey, if we add macrolide short duration or long duration, is that good? And then you do the same. And then you answer another question. Hey, if we use steroids, would that have been useful or not? And you do it again. And these are all sequential, and it takes a lot of time. And that design's not really the best setup for a pandemic. So what the Remap very briefly aims to do is it's a randomized, embedded, multifactorial adaptive platform trial. And it aims to do a number of these things sequentially. So test multiple interventions at once and actually assess the information as it goes along. So that's the very brief overview. But let me just go through those different aspects in a little bit more detail so you understand the Remap design. So it's a Bayesian hierarchical model, and a lot of it is done in simulations at the start. So when you're starting, you have to figure out, obviously, what are you going to do? What disease condition you're going to look at, and what are you going to stratify for at the start? So there's some initial considerations have to go in. And when we thought about Remap CAP, well, why did we pick CAP? Well, for 2 reasons. CAP is important. A huge number of the patients in our ICUs have community-acquired pneumonia. And there's a number of important questions we need to ask. And as I alluded to before, what antibiotic? Should we use long duration of macrolides? Should we use steroids in these patients? We don't know. But a huge reason for using this for pandemic preparedness is community-acquired pneumonia, or a new viral community-acquired pneumonia, is the canary in the coal mine for a new pandemic. And again, we saw this unfortunately with COVID when it arrived. So we looked at patients with community-acquired pneumonia, but that allowed us to get our infrastructure in place, select sites to develop protocols, get them approved, ethics, regulatory approval, to get a lot of that infrastructure already going and already running, so that in the first day if a pandemic comes, we actually have all of these things in place and we can transition. We have to randomize. It's how we determine inference, and it's how we draw our conclusions. So Remap CAP uses response adaptive randomization. And essentially what this means is we start off 50-50, but as the platform learns, and if one intervention is better than another, then actually patients are preferentially allocated to the group that is doing better. So, and again, you can see how that's very ethical, and it's actually also very useful in the event of a pandemic, that as we learn, more patients receive the treatments that seem to be better. We have to embed it into clinical practice. Unfortunately, as we all saw, the world fell apart when COVID arrived and our ICUs got unbelievably stretched. So as much of the research practices needed to be embedded into day-to-day practice so that it is easy, so that a new research project isn't a big ask for staff, that it just happens seamlessly. And then multifactorial, and I alluded to this earlier, that we can answer multiple questions at the same time. And that's really useful for two things. Well, we get more answers quicker, so it's really efficient, but also we can look at interactions, and we'll see when we look at steroids and IL-6 receptor antagonists, but being able to tell that there's a positive interaction is really useful information. And it's pretty unique to this sort of design. We gather the information, it's collected in regional sites, it's processed, and then we actually look to say, well, have we hit our trigger for superiority, inferiority, or futility? We also got external information, and this happened a few times during the study, where we got information from other trials, and we were able to bring that knowledge in, and that would allow us and the DSMB to decide whether we would stop an intervention, declare a success, and move on. And a really neat aspect of this is if we declare an intervention as superior, it becomes part of our standard of care. So we actually can translate our results into practice seamlessly and rapidly. So as of this morning, REMAP-CAP had randomized just under 10,000 patients into just over 17,000 interventions. And as you can see in the second thing, so the vast majority of these have been in COVID, over 8,500 patients with over 15,000 randomizations and in over 330 sites so far. So maybe just to go back and just give you an idea of what's being tested. So in the CAP domain, so this is the peacetime domain that has been running for 3 years. We're looking at various antibiotic strategies to see which one is better or not. In combination with these antibiotics, well, is it a standard or an extended course of macrolide useful or not? We were testing steroids, and to see no steroids, fixed dose or shock-dependent hydrocortisone was beneficial. And one of the real advantages this you'll see is when this was already running, and when the pandemic arrived, we were immediately able to randomize patients with COVID into this steroid intervention as well. So we were able to actually start our steroid trial immediately when we decided to pivot to a pandemic. For this group, which has a huge experience and interest in ventilation, we have a early phase ventilation trial, which is actually testing clinician preferred ventilation, so whatever you fancy, versus guideline recommended, which is essentially ARDSNet. And this is a few advantages. It's going to determine what our current practice is. It's going to give us information to see, as many of us have thought, and the reason many people don't follow the guidelines is the bedside clinician knows better than ARDSNet. So it's essentially the clinician versus Big Blue. Is that going to work? And this is going to become this preliminary phase, when it finishes, will become a secondary phase where we pick a number of very definitive interventions. And this will be the first ventilatory strategy trial embedded within a platform trial. So we're super excited about that. And we're getting ready for flu. COVID's with us. COVID will hopefully go soon, but flu will hang around as well. So we need to look at flu. And maybe just to give just a flavor of some of the results of REMAP-CAP. So in these, there's Kaplan-Meier curves on the left, and our primary outcome was mortality, which is dark red, and organ failure, which is more organ failure is red, going to blue, which is less organ failure at day 21. So more red is bad. So in ICU patients, we showed there was over a 90% probability. So we stopped before our normal 99% trigger because of the recovery trials, but we found that steroids were more effective at reducing death and organ failure at day 21 than no steroids. And as we all know, that's now incorporated into local and global guidelines. We also found that, so we were testing antivirals to see if they were beneficial or not. And we found that actually hydroxychloroquine, or a combination of hydroxychloroquine and Kaletra, was not effective. It was detrimental. So there was, you can see more red there in those arms. There was more death and organ failure with those, and Kaletra on the very bottom had no effect at all. So we can see that it's useful to show that things work. It's very useful to show that things don't work as well. And we're now looking at ivermectin. We've randomized 120 patients into our ivermectin domain. We looked at IL-6 receptor antagonists, and as everyone here will probably know, they have shown to be effective. They reduce death and organ failure at day 21 and are now part of guidelines. And we looked at therapeutic anticoagulation in the critically ill. This was not beneficial, and it was actually harmful. So that practice for therapeutic anticoagulation in the absence of a clear indication for it is not helpful and might be harmful for IEC patients. Interestingly, when we looked at the ward patients, the opposite was the case. It seemed to reduce death and organ failure in those patients. So it seems to be beneficial in the ward and not effective in the ICU. And that's really interesting as well. That is a differential effect. And again, just most recently, convalescent plasma, which many people thought would be very effective, actually is not. Okay, so I think you can see we've found a whole load of things that have worked or have not worked in COVID-19. There's a number of other interventions that we're testing. And as I said, the ventilation domain would probably be of interest to many people here. There's a lot of ventilation enthusiasts and experts. And again, this platform design will continue to deliver in COVID, but we also hope in CAP and flu in the future as well. We think it did what it said it would do in the tin, and that when it hit the fan, we were actually able to deliver results to the bedside. Apologies. And but what this whole meeting, what this whole consortium is about, as our friend Ken Valley eloquently said in this editorial, is it's all about harmony and working together. It's all about collaboration to deliver these results. So I'm happy to answer any questions and just thank the consortium for all the work it's done, for all its collaboration. And I continue to enjoy working with it and to see where we can work with REMAP-CAP in the future. Thank you very much.
Alistair, on behalf of the group, thank you for your work with both the consortium and straddling the divide between the consortium and REMAP-CAP. Our hope is that we minimise that divide, and we've been chatting a lot with Derek, that Alistair alluded to. There does seem to be a lot of harmony between the Celtic fans across the world. Derek is also a Celtic fan. So that we are hoping to try and assist REMAP-CAP. I think the interventional studies are important. And if we can help that with 18,000 observational data, as Al says, then that's a great thing. We can get the observational data, but for sure the interventional data and the studies that REMAP-CAP have done so well are incredibly important.
And John, I think you've hit the nail on the head. You know, if this consortium can generate the hypothesis and generate the questions, it's the other platforms can then start to answer them. And the great thing is that like a consortium like this is we can show that these questions are not linked, you know, say just to Brisbane or just to Queensland or just to Australia, that actually it's the same questions in many different places globally. And I think that brings a huge power to the need to answer the questions. So it's useful for finding the questions and prioritizing them.
Absolutely. And I think, you know, once you get 35 million data points and you look for associations, a lot of them will be rubbish, entire rubbish, and we just wipe them out. But looking at federated learning, which is one of the things we've been interested in, Derek, Angus too, but also bringing bringing the power of Gates to this, and just so there's any crazies still online, Bill Gates won't be getting your data. But the ability to look at machine learning and artificial intelligence, to look at potential associations and then say, to Alistair and Derek and Steve Webb and the REMAP-CAP, hey, listen, this seems to be a consistent finding. This is a hypothesis generating platform that then moves up to the REMAP-CAP. And we hope eventually that the, if we can do with David that you heard from Iridia, if we can do the dashboard well, it may be able to feed these data immediately into REMAP-CAP, which dramatically reduces the amount of workload. So suddenly we can do, as REMAP-CAP has done very, very well, in clinical interventional studies much more rapidly. We all know it's a pain in the backside doing them. But if we can get these data in once rather than twice, and we can say, you know, when we put the data in the dashboard, you know, ping, Pauline, this patient is suitable for REMAP-CAP study XYZ. Would you like to put them in? If we can do this, and we're not there yet, but my goodness, that creates a huge amount of power. And that is as Kenny Bailey says, harmony, not hegemony. So a fantastic opportunity, and if we can tie in with Remap Cap and a system with their outstanding work and their outstanding studies and results, that would be a fantastic outcome from us. Al, thank you for that. We're going to keep moving on, and we're going to take some questions at the end, if that's all right with you. We're going to move from Ireland over to Maastricht to our good friend and colleague Roberto Lorusso. Roberto has been on with us a number of times this week with the ECMONet and some of our papers that our Estonian colleagues have been creating. He is obviously a proud Italian working in the Netherlands at the moment. And his question is, have we forgotten the heart in the middle of COVID? So, grazie mille, maestro. Please take it away and give us your slides.
Hi, John. Thank you very much for the kind invitation. And I just want to highlight, as everybody did so far, that your really endeavor, your efforts were so inspiring. And I think we learned a lot also during this day. So let me share my screen and start with this kind of question. And I think, I hope you will agree with me. Did you see my screen?
Yep, screen's on for you. Thanks, Roberto.
Yeah. So first of all, these are my disclosures. So I'm going to, however, became rather evident. Oh, sorry. Yeah. And sorry, just a moment. I have a problem of yeah. So sorry again, because I prepared the presentation on registration in case there was any kind of technical issue. So these are my disclosure. So this is just to highlight that there were a few papers at the very beginning of a pandemic who underlined a few facts that afterwards they were either very, let's say, familiar and popular among all the clinicians, like this one about the acute pulmonary embolism. This was published at the end of March, unfortunately, and we know how common these episodes were afterwards. And then afterwards, in April, just the first evidences about the coronavirus in the myocardium. So these very important papers were just case reports, but I think in one way they just underlined what happened very frequently, but on the other hand, what was, I think, underestimated. But we know now that there are some clear pathways and mechanisms of the virus, which of course have been discovered or, let's say, highlighted. And you know that now we have a lot of evidences for a microvascular impairment with the viral invasion in all the organs and compartments. But regarding the myocardial injury, we know that there have been a lot of, and a serial of publication highlighting the type of myocardial injuries, but there are for sure some specific issues which are, I think, more common and which should have been more, let's say, appreciated by the clinician, and I didn't think that was the case. So like sepsis, like, you know, of course, beside acute pulmonary embolism, which was after a while addressed, but particularly the microthrombosis and all the other things which have been really showing afterwards in these COVID-19 patients. Indeed, if you look at what is the prevalence and the type of impact, the paper from Lala and colleagues were really, I think, a very important one, because they look at their COVID-19 patient and they showed that 36% of the patient had the clear involvement of the myocardium, looking at the troponin levels. But looking at the extent of the troponin release, they could show, of course, that there was a direct relationship between the troponin release, so therefore the myocardial injury extent and the in-hospital survival, as you can see here. But after a while, what kind of myocardial injury? So Of course, we have the troponin release showing us the extent, but what kind? And this is another very important paper because these authors, they look at the type of injury and differentiated an acute or chronic myocardial injury. So with patient having already history of myocardial involvement or patients showing something acute. And in the more than 4,500 patients, they looked at the acute myocardial injury was present in more than 30% of the patient, again, 30%, but particularly almost 80% of this cohort of patients had signs of acute myocardial injury. So again, much more frequent the acute effects of the induced by the coronavirus. And you can clearly see from this figure the impact of acute or chronic, so all the presence already of a cardiovascular disease in patients then affected by COVID-19. But very important, this study from Putman and colleagues, they had the chance to look at 100 patients, a COVID-19 patient, and they showed that the cardiac involvement through MRI investigation was present in almost 80% of the patient, but particularly in 60% of these patients, there was an ongoing myocardial inflammation. So again, highlighting the remarkable impact of the COVID on the myocardial state. But what about the echocardiographic signs? And this is, you can see that the amount of abnormal left or right ventricular function was present in more again than 30% of the patient. And in the 3% of the patient, you can see that the echo was able to change the management in the ICU of this patient. Another important issue looking at the echocardiographic abnormalities was particularly important to highlight the right ventricular involvement. And you can see that there are several parameters which were independent predictors of in-hospital death. And this is again to highlight how the right ventricular function or abnormalities were important for in-hospital survival. And indeed, Corica and collaborators look at the extent of right ventricular dysfunction in COVID-19, and they found that 1 over 5 patients, so 20% of the population, had a severe right ventricular dysfunction, and this was, of course, absolutely related to in-hospital outcome. So if we had from 20 to 30% of remarkable involvement of the cardiovascular function or the cardiac function, myocardial function, so how was this translated in more mechanical, or how was the mechanical cardiocirculatory support extent in these patients? And with the EuroELSO, as you know, study which is ongoing, we look at this amount, and you can see clearly that the amount of VA ECMO or VAV, so with the concomitant cardiorespiratory support, was really always below 10%. This was the first wave. And then we have the second wave, again, less than 8%. The third wave, 8%, and the current fourth wave, you can see we have the last report of 15 November, it's 7.6%. So much, much, much lower than what has been reported about the serious cardiovascular involvement in COVID-19. And in the ELSO registry as well, so beside the EuroELSO COVID survey, we saw that the cardiac support, so associated cardiac support with respiratory support, was present only in 3% of the patient. We made just now a submitted publication, a systematic review about the use of mechanical circulatory support in COVID-19 patients. We could see, we could evaluate more than 2,500 patients. And you can see that the amount of cardiocirculatory support in this systematic review was present only in 6.3%. And you can see the survival of this patient was 31.4 against more than 50% of the patient undergoing only respiratory support. But I think we should really look at something different. So this is, I will say now, quite famous report from Mustafa and colleagues from Chicago. They use in 40 patients a combined right ventricular support with a VV ECMO with a Protect Duo cannula. You can see hospital discharge 82.5%. Impressive. The same group look at more patients afterwards, and they look at the 80 patients with another publication compared with a mechanical ventilation only COVID-19 patient, and they made the propensity match analysis. And I would say again, the results were impressive. And you can see here, inotropic requirement in the ECMO combining cardio and respiratory support was 1.3% only against more than 36%. And also look at the septic shock, 17.5 against 55. But even more important, look at the impressive difference about renal and hepatic disorder. And finally, of course, the mortality, which in the ECMO group was the mortality was 25%, so with 75% survival. And look here, almost 75% mortality in the mechanical ventilated. And this is, of course, clearly shown in this figure, the differences in hospital survival. But then Tature saw the same group again, presented just a few weeks ago, 136 patients, and all had less than 2 weeks of mechanical ventilation before ECMO. And you can see here, what is also very important, they made a pulmonary artery catheterization, and they could see severe pulmonary hypertension in all of these patients. Tracheostomy 13%, and here the mortality was very high. But what they saw is hemolysis with a flow higher than 4.5, and sometimes also cannula fracture. But, and you can see the Protect Duo cannula here in from the jugular vein to the pulmonary artery. But I think what is really important is another publication from Keijinkai and colleagues, again with the same ECMO configuration, so cardiorespiratory support. You can see procedure duration only 16 minutes, duration of the support 13 days, but look at the device-specific complications, 0, and also the survival to this device explant, 85% almost. Again, impressive results. But again, what is, I believe, the reason for that, if you look at this very important difference in hospital mortality between ECMO and non-ECMO, but is about the extent of organ damage in this patient. You can see in the patient receiving cardiorespiratory support with the right ventricular support, no whatsoever, no acute kidney injury, so very important. And again, the striking difference in hospital mortality. So for this reason, we say, and we are really convinced that in COVID-19 patients, we think we should have performed a little bit more aggressive, I would say not only veno arterial, but also cardiorespiratory support. And maybe the combination of VV ECMO plus right ventricular support could be the key. Just to finish, I think that I want to highlight that the European Society of Cardiology just released part 1 and part 2 regarding the epidemiology, pathophysiology, diagnostic, and treatment and follow-up of COVID-19 patients. But if you look at what they did and what they released in recommendation, it's really, really limited in terms of mechanical circulatory support. And of course, they say that ECMO should be the preferred temporary mechanical circulatory support in case, but nothing more than that. And you can see that they just released some very generic recommendation about how to improve the decision making. So no real dedicated pathways, and also that if you can use this support also in patient prone. And again, you can see that in the algorithm proposed, you can clearly highlight, you can clearly appreciate that there is really nothing more than very generic recommendation about considering ECMO if strictly needed. And I think this is really something which should have been more, let's say, discussed and provided with more information. Again, the same story here, which says that no clear recommendation could be given regarding the treatment of patients of COVID-19 with myocarditis. So maybe mechanical support can be considered. So really, again, something like a confused recommendation, which I don't think it was really a good recommendation in this case. So in conclusion, I think that first of all, we all know now that COVID-19 has been, no matter what, an extremely and of course difficult challenge for the ECMO community worldwide. But I think what we missed in some ways is that there is a clear sign, or there are clear signs of concomitant cardiovascular compromise. I would say between 20 and 30% of these patients. And unfortunately, if you look at the numbers, we have seen that the cardiorespiratory support is performed less than 10% of the cases. But I believe that there are now some series showing clearly that the association of a particular right ventricular support and respiratory support maybe could be the key in this patient to have a really impressive result, in-hospital result, as shown by Mustafa and Kind and colleagues. Thank you very much for your attention.
Roberto, grazie mille. Thanks as always, a fantastic presentation. Look, I think it is an interesting area that the heart has been perhaps overlooked. I'm going to pass over to my good pal and occasional sparring partner, Giles Peake, to introduce Matthew Griffey. Giles, over to you, please.
Thank you very much. And again, I'd like to commend you for your fantastic vision and leadership. So Matthew Griffey's been heavily involved in ECMO and COVID critical since the beginning. He is from Utah and he's going to tell us about COVID in the high desert. Thank you, Matthew.
Thanks very much for this opportunity. We're talking now in the next few minutes about some lessons of the pandemic from the vantage point of the high desert here in the Intermountain West. The University of Utah is a referral center in a large area that is a substantial part of the United States. We're in the midst of rangeland, mountains, and rugged wilderness, and we're one of the only places that offers ECMO and other subspecialty care for ARDS within hundreds of miles. My name is Matthew Griffey. I'm on the faculty of the University of Utah. We have kind of a hidden little abstract here by my medical student, Bradley, and neither of us has any relevant conflict of interest. Go ahead, Bradley. Let's hear your presentation on the next few slides.
All right, thank you, Dr. Griffey. So I'll start just by showing this map of the United States, which highlights Utah in red, and in gray is the geographic illustration of the Intermountain West referral zone. The University of Utah is the only medical school in Utah, as well as the only academic referral center for many of these rural states located between the Rocky Mountains and the West Coast. And as you can see here, this area constitutes quite a substantial chunk of the country. So on the next slide, what I looked into on my database review of critically ill COVID patients was specifically ethnicity and gender. So the green bars on this graph show the ethnicity of ICU patients as a percentage of the total ICU admits, while the blue bars are showing the ethnicity of the Utah population based on the latest census data. So what we can see here is that 79% of the Utah population is white. However, only 32% of the COVID ICU patients were white. In comparison, Latinos make up only 15% of the state census, but came in at 40% of the COVID ICU population. Aboriginal or Native Americans account for only 1% of the Utah census, but made up 14% of the COVID ICU admits. So the major take-home point of this slide is that in Utah, as seen in many other countries, the non-white ethnic groups were disproportionately affected by COVID-19. And moving on to the next slide, we can see that these ethnic disparities in COVID-19 carry on also to outcomes. A review of the disposition within the case report showed that mortality for Asian and Native American ethnicities in our ICUs were about 50%, compared to 33% for Latino and 23% for white. Fortunately, our Black COVID ICU patients had 100% survival to discharge. And on our next slide, we did have a hypothesis that these differences in ICU admission and survival for non-white patients might be related to delays between the onset of COVID-19 symptoms to hospital admission. But we can see here that there was actually very little difference in time between symptom onset and admission by ethnicity, going against our initial hypothesis. The next step that we are interested in investigating is to see how many of these non-white COVID ICU patients actually spent time at a smaller hospital before being transferred to the university compared to the white COVID ICU population. On our next slide, we see another area of interest in our Utah data was outcome by gender. This slide just shows that the mortality was 34% for males compared to 26% for females. Data not shown is that the majority of our COVID ICU patients were indeed male, 62% compared to 38% female. And then this data from the Utah Department of Public Health shows that the timing of the COVID pandemic waves has been about 6 months behind the peak crises of the European and Northeast waves. Our first surge crisis was in the winter of 2020, during which we did have to open an extra dedicated COVID ICU, and we're currently in the midst of a second wave, which has caused stress for staffing, bed availability, and is a continued evolving crisis. We no longer have staffing for a dedicated COVID ICU, but the patients are being cared for throughout multiple ICUs in the hospital. And on this next slide, we can see that even in small rural areas of the Intermountain West, the Delta variant, shown in the orange-brown color, accounts for the majority of cases. COVID has definitely shown us that being in a rural and remote area may delay the spread of a virulent pandemic, but the world is incredibly closely connected. All right, I'll turn it back over to you, Dr. Griffey. Thank you.
Thanks, Bradley. Here's some overview data about the health disparities, which are a major theme of COVID-19 in our area, thanks to our VP for Health Equity. The bar graphs at the bottom show that this is not just a subtle trend, but the case rate of COVID is 5 times higher for Latinos than for whites, and twice as high for Native Americans than for whites. For Pacific Islanders, the rate is 4 times that for whites. The factors thought to be behind this include considerations such as difficulty for some of the ethnicities in any sort of remote work. A lot of the communities who've been disproportionately affected have multi-generational families and often are in high density households. In response to this, thousands of letters and emails went out to hotspotted zip codes with materials in Spanish about public health measures to stop the spread of the virus. And testing was also taken into neighborhoods besides just education. And the left slide shows a testing tent set up in a Hispanic neighborhood center. The bottom slide shows the wellness bus, which was repurposed as a testing van, and it was deployed at the Utah Pacific Islander Health Coalition. In the first wave, we were seeing what was happening in different ethnic groups. In the second wave, things have shifted a bit. What we're seeing is the Delta wave is a vaccine disparities wave. The map on the right from the CDC shows vaccination rates by population. The states with the best coverage are in the far northeast, or the dark blue ones, followed by the whole West Coast. Utah, Nevada, and Arizona have lower vaccination rates, but our neighboring states just to the north of Utah have even lower rates of vaccination, rivaling the other problem area of the central and south US, which Dr. Barrett just alluded to. This reflects a crisis of access to accurate information and cultural and political barriers to implementation of evidence-based healthcare. The result has been 9 out of 10 of our ICU patients in our current surge are unvaccinated. I'm so grateful for the contacts for peer advice I've met through the Critical Consortium. Our administration did a review of our COVID ECMO practice, showing for this set of 13 COVID ECMO patients, the average ECMO run was 32 days, but for a number of patients, it spanned a substantially longer time. The administration said they were concerned about ECMO runs being longer than necessary and suggested we should aim for a 2-week limit. I asked for some feedback and perspective from consortium contacts, and the feedback was that 4 to 6 weeks was actually an expected average for COVID ECMO, with some patients turning a corner only after 2 full months of ECMO. The perspective from other academic centers who are dealing with this, trying to get a balance between resource limitations and the snail's-paced natural history of COVID-19 has been invaluable when working from our isolated ECMO referral center. What about outcomes? In yellow for this group of 13 ECMO COVID patients are the survivors, the blue are the non-survivors. And it was pleasing to note a 61% survival rate, which was encouraging and in line with ELSO data that ECMO is reasonably effective for severe COVID. One of the biggest lessons COVID taught us about our healthcare resources is that the bottleneck for resource-intensive therapy is not vaccines, medications, or hospital rooms or PPE, but the people who do the care at the bedside, minute by minute and hour after hour. Our hospital nurses were in high demand, and a nursing shortage was the major challenge in dealing with the surges. The shortage was severe enough that we've had an emergency measure to make student nurses able to work in our ICUs. Besides ECMO, we've been through many different iterations when looking through the database on things that were both a so-called trial of one as well as actual randomized trials. In finishing up, I wanted to present the case of a 37-year-old female who is a nurse from Wyoming. Her case illuminates many aspects of the COVID crisis in the Intermountain West. She's a fully immunized hospital nurse who has rheumatoid arthritis and is able to work because her arthritis has responded to rituximab. Unfortunately, the rituximab probably prevented a robust response to vaccination, and she contracted COVID at work from patients in her Wyoming hospital. She was transferred to the university at the end of August and ended up on ECMO for about 2.5 weeks. Thankfully, she recovered and was able to go to inpatient rehab and met all the goals. And when I talked to her a few days ago, she had a strong voice and was extremely gracious and full of gratitude for the care she had received and the amazing progress she's had. And I can't express enough how grateful I am for the input from the people I've met through this consortium for input on these very aggressive and challenging therapies in order to get people from failing ventilation back to home. Thanks very much for your help and interest and support throughout the pandemic.
Thank you very much, Matthew. That's a fascinating dive into health inequalities. Obviously, genetically, all of these minorities around the world have no more relation to each other than various white populations have to each other. So what can we do as intensive care clinicians to reduce health inequality?
The thing that is being worked on is actually trying to have better education on the front lines, and this is an effort that is a major priority at the university as far as trying to do not only outreach, but actually is a giant theme that's come up of moving from kind of awareness type stuff to actual inclusion things, and trying to get input to the community leaders of areas that have been hard hit, but obviously goes beyond the scope of inpatient medicine. It's a lot of public health and community health things.
Yeah, thank you very much. So I'm going to move on in interest of time now to the next presentation, which is Dr. Heidi Dalton from Inova Fairfax in Virginia and also Arizona, who's a long-time ECMO and ELSO person. And she's going to talk to us about outcomes of COVID patients during surge COVID ICU phase and during the other phases. So Heidi, are you on?
I'm on. Can you guys hear me okay?
Yes, thank you.
So thanks for inviting me. Here we go. Here are my disclosures, none of which really matter to this talk, I don't think. Certainly, we've learned a lot in the last couple of years as the COVID pandemic rages. But one of the things we're going to chat about, as you've heard also from other speakers, is about outcome. And we know that one of the lessons that we've learned very early on is that COVID kills. I mean, this is data from the Hopkins website just showing you that there have been now over 5 million deaths related to COVID. And you can see the number of cases, which are astronomical. You can also see the fatality rates there on the right in different countries that have been reported in the literature and to the Hopkins board at least. And if we look at our own data from the COVID Consortium, you can see that thank you to our friends in Spain and Italy and everyone that has contributed data, we're now up to almost 16,000 ICU patients from around the world, from every country that are helping us to refine our care and our outcomes for these patients. We know that many ICU patients require mechanical ventilation or ECMO, and this is just a flow chart that comes from the COVID Consortium, looking at the number of patients that get ventilated, the number of patients that need ECMO. And as you can potentially see in this particular slide as well, we have a death rate of about 33% that's reported, although there are a lot of patients that are still in the unknown phase as to their ultimate disposition. You can also see from this slide that there seems to be a variance in terms of death and discharge rates based on timing of when you're admitted and what types of potential comorbidities and such that you have. And certainly there is, again, this large component of unknown or unfinalized data, which will help us as we refine our outcomes and move forward. We also know, as you've heard from others, that ECMO is being used at increasing rates. This is just data, again, from the consortium, looking at the number of ECMO patients that have been reported to the registry over the months since the pandemic started back in 2020. And this is data from the ELSA website, just looking at the fact that now there are over 10,000 ECMO cases that have been reported, predominantly from North America, but certainly from other areas of the world as well. And at least 8,000 of those are patients who have ECMO initiated at least 90 days prior to this slide. And if you look at the death rate for these patients, you can see that overall, there is about a 50% death rate in total, and that includes patients who have ARDS as their primary illness. This is a review that you may have seen out very recently, comparing the ELSO registry in periods before May of 2020 in centers that used ECMO relatively early, compared to group A2, which is the same centers, but looking at a later time period between May and December of 2021. And then group B, which is sort of late adopters of ECMO. They didn't start using it until after May of 2021. And certainly, as you can see here, there is a difference in mortality that has been reported in these particular groups. You can see that group A1, sort of the early adopters, have the lowest death rate as compared to group A2 and to group B up here. They also found that early on, when you looked at the early adopters here, A1, that if you supported more than 9 COVID patients per center, that your outcomes were somewhat better. So I think this indicates, that there is a learning curve. ECMO does work, because even if you look at, the highest death rate here, there's still about 50% survival in that group, but certainly more work to be done in terms of optimizing outcomes. From the same study, what did they see? Well, they found that in terms of changes over time, they found that patients supported in the later time period had more use of high flow nasal cannula or multiple non-invasive supports, less duration of endotracheal intubation pre-ECMO, more use of steroids and remdesivir, less hydroxychloroquine. And certainly, if you looked at the centers that had more experience versus the late adopters, there was more use of prone positioning and neuromuscular blockade in the ECMO patients as well. We've also seen an increase in ECMO duration over time from like 14 to 20 days. And as I mentioned, early adopters with higher patient volumes did better as well. And if you compare that to other experiences, this is the Paris hospitals, also looking at patients before and after July 1st of 2020. And they also noted that survivors did much better, actually, after July 1st, even though ECMO-related complications did not differ between centers. They also found that in their population, that things that were associated with death were, if you got admitted after July 1st, that is, patients in the first wave actually did better than patients in the later waves. If you were older, if you had CV component scores of the SOFA score that were pretty high, they also saw that if you had longer ICU duration to ECMO time and higher levels of PCO2, that was important. And actually, though, when they imputed missing data, they found that the admission date before and after July 1st of 2020 went away, as did actually the use of steroids, although certainly I think we all believe that steroids have been helpful. They didn't find that there was a duration of ECMO that was different. They didn't find an ICU stay or hospital length of stay between the two periods was different. They did find in the post-July 1st period, there was less neuromuscular blockade and less use of inhaled nitric oxide. As has been reported by others, certainly they use a lot of proning in their center, and as the consortium has shown, actually proning before, during, and after ECMO may be associated with better outcomes. More use of steroids, more air leak, which has also been reported by others. And they did find that there was some more hemolysis and more circuit changes that were needed later on in their patient population, although there was no difference in bad patient complications in terms of stroke. Now, what are some of the reasons why we're seeing changes in outcomes? And certainly this whole idea of variance may have an important role in this. This is just one sample from LA County here in the States, just showing that we've sort of switched from the Alpha variant to the Delta variant, which is known to be more contagious. Maybe that has something to do with outcomes as well. And certainly, I think, has been mentioned by others, this whole idea of vaccination. Again, this is from the LA County data, which is a fairly large number of patients. Just looking at patients that are admitted to the hospital who are vaccinated, unvaccinated, and partially vaccinated. And certainly there are areas of the world where vaccination is not as prevalent, easily available as it is here in my country, but certainly it is annoying, I think, to a lot of us that even though we have vaccination, which is readily available here, people are anti-vaxxers, or there's a lot of misinformation about vaccination. And so not everyone is getting vaccinated. And if your ICU is like my ICU, the predominant number of patients that we see requiring ECMO are unvaccinated patients. And even in the vaccinated ones, they're ones that have high levels of comorbidities. Another explanation for changing outcomes has been the impact of pre-ECMO ventilator use. This is one small study from San Antonio in which they looked at 52 patients and found that they had a 56% survival to discharge. And they found that longer durations of mechanical ventilation were associated with death, and that was adjusted for a lot of comorbidities and cofactors. The other thing that was interesting about this study is that they placed 12 patients out of the 52 directly on ECMO prior to mechanical ventilation, that is just from non-invasive ventilation, and they had about 75% survival in those particular patients. Again, just showing you here that at least in this particular cohort, pre-ECMO ventilator days and actually post-ECMO ventilator days were both associated with poor outcomes, and that outranked things like age, sex, your BMI, and the number of comorbid conditions that you had. This is a study from my own center at ANOVA, in which we've used, this is between us and Cooper, which is in New Jersey, ECMO on about 78 ECMO patients. And we actually found that use of non-invasive ventilation for greater than 3 days was associated with a hazard ratio of 0.46 in terms of getting off ECMO, and they were less likely to have hospital discharge, although overall discharge in the hospital itself was not different. And this persisted after adjustment for a lot of things. So this whole idea of non-invasive ventilation and spontaneous breathing injury has been somewhat that's been reported by others, although actually I just saw a report yesterday actually saying that they found that there was no difference in another population. So another area I think that we need to look at in terms of self-induced lung injury. The other thing I wanted to throw in here is just to remember that, when we take these patients off ECMO, it's not like they're magically better. This is again from the San Antonio series, in which you can see, even though their PF ratios are better when they come off ECMO, they're still pretty sick. I'm not sure we'd be taking patients off necessarily at my center requiring FiO2s around 70%. But you can see that these patients are still pretty sick, and they require a lot of care after they're off ECMO as well. The other thing is it's really hard to predict who will survive and who won't. This is a CT of a 19-year-old that I took care of recently. And you can look at this CT and say, wow, these lungs are pretty bad. I wonder if this guy is going to make it. But I will tell you that this patient is off ECMO, just pressure support on the ventilator and doing quite well, indicating, I think, how sick these lungs can get, but how patients can recover as well. In our own particular center, one of the things that we've noted, again, is the higher use of non-invasive ventilation, which may be associated with poor outcomes. We have seen in 2021 that our survival is worse than it was in the early ranges. The other thing that we've noted is that at one point we were able to support up to 14 patients in the first wave because we weren't doing other things like cardiac surgery, elective other surgeries, that sort of thing. And we had to expand to other units that had never done ECMO before and do emergency training for the nurses and the docs. And initially those outcomes weren't so great. Now that particular problem has sort of gone away. But I do think this whole idea of ethics and who gets ECMO and who gets something else is something that's going to be a problem in the future. And as Matthew mentioned, our primary problem has been nurses. We cannot keep adequate nurses, not only to care for the ECMO patients. We used an outsourced ECMO team to provide ECMO care, but bedside nurses, we have a very hard time keeping. And in terms of how to solve that problem, I hate to say it, but I think money is one of the reasons. If you're a young nurse now and you can travel, and travelers make 3 or 4 times as much as a bedside critical care nurse, we are losing a lot of nurses to travelers who may not be as invested or long-term in your center, and therefore may not be good partners in terms of protocols and long-term longevity and continuity. We also are seeing more air leak and certainly more secondary infections in these patients. And this is just an example of one man who had just horrific air leak. Even if we took him off the ventilator, we could not stop his air leak. It continued. We were unable to control it, and he eventually died. So recapping very quickly then, mortality in COVID patients overall may be decreasing in some groups, but not in everybody. Does prolonged spontaneous breathing and non-invasive methods increase risk of lung injury? Not really sure. The data isn't really out there. I do think ECMO is appropriate in the severely ill patients, as many of us have mentioned. I do think we're going to have ethics problems in terms of who to put on, what to do with excess patients, need for training personnel. I do wish that everybody would get vaccinated. I will just say that up front. But I do think that the consortium has been very valuable and would continue to be very valuable to help us guide management with global data, help us identify where research needs to go first, and provide a lot of data points which we can use to improve outcomes in our patients overall. And I would just invite you, if you're not already a member, to join us. And thank you very much for your attention.
Thank you very much, Heidi. Every time I thought of a question or a comment, you came up on the next slide with the answer to it. I think that was a fantastic overview, and thank you very much. There are no questions in the chat, so we're going to move on to the next speaker, who is a fellow expat European, Floridian, and cardiac surgeon, Nicole Brozzi from Cleveland Clinic in Florida, who's going to talk to us about ECMO and COVID-19 respiratory failure. Shifting paradigms in indication. Thank you, Nico.
Thank you for the opportunity to present. Can you hear me well?
Yep.
I'm glad. Okay, let me share the screen and get going. So I very much appreciate the opportunity to present our experience on behalf of the village, of our team that has dedicated their efforts. No conflicts of interest. By the way, all the images have been authorized by patients or families that we'll be sharing, and really a honor to present on behalf of our team. just as a way of introduction, we are a rather small campus of 250-bed hospital, part of a 5-hospital system here in South Florida, within the larger Cleveland Clinic system. And so we provide services within the southern area of Florida. As we got involved into all this, into the pandemic, of course, with the information that was described regarding the uncertainty about the usefulness of ECMO. And so we were just rolling out and establishing our ECMO program in early 2020. Actually, we just sort of made the cut before this recommendation came out of against starting ECMO programs for the purpose of providing specific services for COVID-19. And so we were just getting started with the education and to our nurses, and there came the challenge. Certainly, we embrace within the different centers across the state as we were trying to understand how we would face and how we would share resources across the state. And that was beneficial, sharing experiences early on. And so definitely, as I mentioned, it was a challenge. It's about training the team. Eventually, as we had the progressive isolation and distancing among caregivers, and so the communication, remote monitoring, and so we got involved in all this with in these conditions and with some general principles as announced and shared by the guidelines that were being published at the time by ELSO, ASAIO, and so about no CPR, avoiding single cannulation, getting ready for prolonged ECMO runs, and certainly trying to protect the caregivers early in the pandemic. Before we knew, we had our first patient coming in, and actually, had to step out to help on a neighboring hospital 90 miles from our hospital. Rather sort of more senior patient, 62 years old, who had come from England, a trip in England the week before. And so he became our first patient, evolving over the course of 24 hours from intubation to really not being able to ventilate anymore. And that's how, before we knew it, we were sort of on the front line of this fight across our country. He did well. He recovered after 3 weeks of ECMO support and 1 additional week on ventilator and went home. That was encouraging for the whole team and encouraged us to keep going. Certainly, we heard and got involved with the consortium very early on, and that was instrumental to us. Many of the things that we then applied help us to develop our program. And we share in multiple, internal education conferences with our teams. Eventually, our patient did well. That encouraged us to publish it as well as initially in the pandemic, there was rather hesitance to perform mobile ECMO. That has since been resolved, and most centers now embrace mobile ECMO to support our patients. And the criteria we used from the beginning was that promoted by the guidelines, by ELSO guidelines, and published in ASAIO. Eventually, as the pandemic progressed and we feel a little more strain, we adjusted our criteria in terms of age from 65 to rather 55 or younger than 55, and very selective cases above that age in terms of weight and no other comorbidities, keeping the standard criteria from EOLIA that we all adopted for the indication in terms of mechanical ventilator. And more recently this year, it has turned into a more dynamic set of criteria that is adjusted according to the condition of the operation of the hospital, in which, as we open up and we have capacity, we are a little more liberal in terms of indication for age and the comorbidities that we use to include the patients. As we reflected in our first year of experience in 2020, it became apparent that in spite of being quite cautious in terms of the use of anticoagulation with heparin, We had some challenges achieving therapeutic ranges in the range of 50 to 70. We had significant, I would say, amount of hemorrhagic complications, including spontaneous psoas hematoma in the contralateral side of the ECMO cannulation of this patient, or massive airway bleeding early after airway intervention provided by the most experienced operators in our team, or spontaneous bleedings in the brain that eventually led to withdrawal of care of these patients. So we started very well with success early on, and that was encouraging. Eventually, we were able to decannulate half of our cohort patients, and the others eventually led later, this is past July, to one reason or the other to withdrawal of support. A little bit what Dr. Dalton referred to as the increasing mortality in most centers, say in that second half of 2020, and as reported more recently by Bairbre from the ELSO experience. And this, I think, is reflecting what we saw in terms of diagnosis, hospital admissions, and mortality for not-ECMO patients across the country as we, in the second half of 2020, as the health systems were pressed across the country with the numbers rising. But it was also interesting, and I would want to bring to your attention that people in general, the press, the media, the general population were becoming aware of the potential use of ECMO and the value of ECMO. And we can see in the searches in Google how they reflect an increasing interest for the use of ECMO in COVID as we had the different waves. And I think this is, and now ECMO became a theme, not only for just like the mechanical ventilator, not only for the physicians, but for the general population. So as we finished the first year, of course, we all became aware of the prolonged recovery course of these patients, the high rate of superimposed infections, and so the challenges to obtain adequate sedation in these patients. And as recommendations evolved, it was very useful that the restrictions in terms of isolation became more loosened after 20 days of the initial diagnosis, and as the caregivers became vaccinated. We learned how most of the time the disease was more confined or with increased affection of the lungs, and eventually we learned to and became all more comfortable with more prolonged ECMO courses. This experience from Chicago that it was mentioned before was an eye-opening for us, and really as we reviewed our early experience, we adopted many of the concepts for the treatment of patients through 2021. And also the opportunity to go and try to offer lung transplantation, not within our system, but actually with other local systems that have the service to patients that eventually are not winning from ECMO. Eventually the experience here, mainly led by the group in Gainesville, has been great with very successful survival. So as we, got into this 2021, we certainly changed our approach to the support of these patients based on the experience that we were sharing and the tips we were picking from our participation, and adopted more liberal use of dual lumen cannula, selective transition to VAV ECMO support, to what Dr. Lorusso was mentioning. The removal of isolation certainly simplified the care of these patients. We were aggressive in terms of early tracheostomy and being more aggressive with physical therapy, change our sedation strategies, anticoagulations, and so on. So in terms of sedation, we moved more to a multimodal PO sedation that certainly facilitated weaning these patients from sedation early after they have been stabilized with ECMO support. We adopted the use of dual ECMO lumen cannula sometimes transition ending off from an emergent femoral cannulation, or sometimes from the gateway if we had the opportunity to transfer the patients to the OR for cannulation. And we were more liberal, since we didn't have Protect Duo, more liberal in the adoption of veno-arterial venous, implementation of veno-arterial venous ECMO support with a graft to the right axillary graft. In those patients that eventually presented some hemodynamic compromise, some evidence of progressive compromise of the RV, or oftentimes what we sort of call air hunger syndrome, these patients that are there supported, but we don't have the room to decrease the vent settings. We are able to decrease some of the vent settings, but then they wake up and they get agitated in spite of trying to manage with high doses of sedation, in spite of using beta blockers in high doses, and so they get extremely hyperdynamic, and they don't have enough reserve to get to a more stable condition to move to the next stage. And really it has helped us bridge the gap and be able to get them right away, do away with that anxiety when they are barely compensating and with the SATs in the 88% or so, and just take that little more step that allow us to get them started with physical rehabilitation. So we've used it in over half of the cohort of patients this year out of the 12 that we've done. In one of them to bail out with the decompensation at the time of the original cannulation, but in the other ones as transition during the progression, again, as we were trying to get them more active and facilitating their ambulation and their physical rehabilitation. Eventually that help us provide stable, prolonged support, and those patients that didn't recover, transfer them for lung transplantation. Anticoagulation, and I'm not going to repeat the concepts, but we all became aware of the importance of anticoagulation, and our experience with heparin had been, I would say, suboptimal. So in January this year, we switched to Bartlett, a direct thrombin inhibitor. And as we reflected on our experience by the middle of the year, we were quite satisfied. This is more extensive experience comparing our 12 patients from 2021. And we see against the 8 that received heparin in 2020, and we see that Bartlett allow us to achieve therapeutic ranges more consistently. Somehow, whatever you may want to do about the interpretation of the values of the dimer or so, whether there was less fibrinolytic events or reflecting and more consistent values and less thrombocytopenia with Bartlett in comparison with platelets. Inflammatory markers elevated on both sides, maybe a little more in this cohort in this year, and similar consistent ECMO support really didn't reflect in terms of the quality of ECMO support, whether we use one or the other anticoagulation agent, a little bit reflecting less thrombocytopenia with the use of Bartlett. In terms of the performance of the ECMO circuit, based on the anticoagulation strategy, we see both anticoagulation agents were similar, didn't affect the performance of the circuit, but we were able to use the membrane oxygenators for more prolonged time on those patients that receive anticoagulation with Bartlett. So in our experience, it turned out to be Bartlett turned out to be a more effective anticoagulation agent, achieve more consistent therapeutic anticoagulation, and allow for more prolonged ECMO runs. We're able to maybe experience some of the initial application of exosomes in a patient that had already sort of been selected and involved in a trial before he actually went on ECMO, and then the family required to apply it and insisted, and so we put it on a compassionate use. The concern with the exosomes derived from fetal cells, stem cells, umbilical cord cells, excuse me, are much smaller in size. The concern with the use of fetal umbilical cells in the context of the ECMO had been related to development of clots or the entrapment in the ECMO circuits, whereas these vesicles are described to contain anti-inflammatory and immunomodulatory agents, but they are much smaller in size. In our single experience, for what matters, our patient did present a decrease of inflammatory markers after the application. This spike is related to a calculus cholecystitis, but we observe a decrease in inflammatory markers after the application of the exosomes and with a correlated improvement in oxygenation. Again, this is a single experience, will require further research. What turned out to be very important in the care of our patients was the active physical rehabilitation with the relentless dedication of our team of caregivers. Certainly, many of the changes we did facilitated that, dual lumen cannulas per se, and that has been described before. The application of arterial venous ECMO support in selective cases, early tracheostomy, and the changes in sedation. These are some images, of the patients as we were getting them from really more prolonged periods at home and to learning to walk again. Then other ones get a little, we had to encourage, and keeping up the spirit with the team has been critical. Sometimes you had to brave them, but the physical therapists have done a great job. What are you checking on your computer? Really? Good job. In terms of how far the field, our experience is now comparing our experience from 2020 to 2021, we did see, a little trend in younger patients. I must say, all non-vaccinated. And I share the opinion from Dr. Dalton, and we try to encourage on a daily basis for patients and families to get vaccinated. A little increased incidence in female patients, and then not significant change in terms of comorbidities. The use of adjuvant therapy as it's been described before and adopting as it evolved. And then more prolonged lengths of stay this year as we went for those longer runs and had less complications. You see, we were liberal in the use of tracheostomy and try to implement it early in the context of trying to facilitate this more aggressive approach. Up to the point that in the most recent 2 or 3 patients, we established the process that we call TRECMO, ECMO, winning down the vent in the operating room, and if the patient remains stable, just doing the tracheostomy. That, as we have found, that simplifies the winning of the sedation enormously. And then we have been more liberal in the use of alternative forms of cannulation this year, with the same goal of facilitating ambulation and rehabilitation early on. We've had the transition of support with the adoption of veno-arterial venous mode in several patients. And well, we've been lucky enough to come with a very aggressive local transplant centers to be able to transfer some of them for transplantation. A little bit of, most of our patients this year have been very active with physical rehabilitation, as we described, and that has resulted in short term of stay in the hospital after being weaned from ECMO. In terms of infection, it was mentioned before, but we were able to document specific agents producing bacterial pneumonia in 3/4 of our patients through our experience. About 1/3 presented bloodstream infection and urinary tract infections. The rest did act well for us, and it turned out to be a good predictor on the outcome of our patients. And it's actually this patient on ECMO support going for lung transplant at 82 days of support today. That will be in green. So this Kaplan-Meier just comparing our outcomes in 2020 with 83% hospital discharge alive to a little under 40% in the first year. And lung transplantation, I'll just take a minute to describe as it became on patients that are going for the long run, and we don't see much improvement in terms of the recovery by 4-6 weeks after the onset. We start entertaining, we start we do contact the transplant center, and so the transfer are really take weeks. Sometimes it may take 4 to 5 weeks, and the whole process of the administrative process with insurance and getting authorization. So we start rather early in the process, and we can always call it out if needed. And we put a lot of effort, improving the general condition of the patient in anticipation for a potential transplant, or will be good anyways if the patient lung condition improves to at the time of decannulation, as we are winning. With every patient that goes for a transplant, there goes our hope, and you know how we all have experienced how invested and how close we come with these patients. And it's been very reassuring when they come to visit, as it is part of the family. If anything, for me, I would point your attention to this picture, as we learn from our patient, that this person here, we don't realize, and we don't, we're so focused in science. This was a person who would clean the room of the patient every day. And she turned into a huge support as they would pray together. And he was hoping to be able to go for his transplant. So this just to reflect how every member of the team has played a significant role in the care and progression and recovery of these patients. We had the opportunity to collaborate and foster international collaboration. You may always, many of you may recognize Dr. Salazar, bringing his countrymen back to Colombia. Her patient had become sick while he was visiting as a tourist, and eventually required over 50 days of support in our institution. And more recently, this patient, and going along with the presentation with Dr. Barrett, who got admitted at 35 weeks of pregnancy, with COVID, required an emergency C-section, failed extubation, and reintubated within a few days, and then was transferred to our care for further support. Eventually, she required ECMO for a couple of weeks and recovered well. And this is 2 months after delivering the baby, and this is her meeting her baby for the first time. With this, a lot of emotions for the whole team, and very rewarding as these patients became very close to each one of us. Thank you for the opportunity to present, and my gratitude to the whole team that has contributed to really make our program viable and to obtain these results currently with over 80% survival. Thank you very much.
Thank you very much, Nico. That's a fantastic overview of excellent clinical program, and I love the patient stories. So in the interest of time, we're going to move on to Dr. Bairbre McNicholas, who's from Galway, and she's going to tell us about acute kidney injury.
Okay, so I'm a nephrologist, and I'm very interested in the what happens to the kidney in generally anything, particularly in ARDS. Prior to COVID, we had an interest in how it happens, what's the frequency with regard to how people get kidney injury. And we know that if you get kidney injury and you're mechanically ventilated, it substantially reduces your survival. And when COVID happened, it's ARDS essentially. We know that its presence increased mortality. And we now know that it also is associated with long-term renal dysfunction. And I think in keeping with the theme of the types of patients that, that were being dealt with, this is a picture from the New York Times. And if you look closely, this woman has a tracheostomy, she's on dialysis, and she obviously delivered a baby a month beforehand. So this this condition really affected a lot of people at all different age groups. And I think it's knowing how this disease develops and the pathophysiology of it and why it's different from ARDS is really important moving forward. Now, we know that going on a mechanical ventilator is associated with stresses on the kidney. The actual process of being on a mechanical ventilator can be associated with increased pulmonary hypertension, and that leads to venous congestion. You can get increased intra-abdominal pressure. The inflammation and the disease process that drives ARDS itself can be damaging to the kidney. So it's thought that inflammatory mediators released in response to damage can cause the kidney's tubular cells to die off, become apoptotic. You can get microvascular dysregulation. So there's an awful lot of interest on this lung kidney crosstalk, and this predated COVID. The reason why the kidney gets injured in COVID is less well understood. At the start, it was thought that the kidney itself was being damaged directly by the virus, and there was a lot of arguments within the nephrology literature of whether you could see direct viral particles or whether this was just actually normal endocytosis within the kidney. One other thought process was that there was a cytokine storm phenomenon, that the increase in inflammatory mediators, particularly IL-6, was directly toxic to the kidney. Coagulopathy and thrombotic microangiopathy were other reasons. And when we biopsied patients with COVID-19 and an acute kidney injury, the predominant finding, unless somebody had an unusual glomerulopathy, was acute tubular necrosis and rhabdomyolysis. So the kidney injury that occurs in COVID is certainly, I think, different than what we get with ARDS. And I think the actual pathophysiology is not quite well teased out yet. In terms of what's been studied for a relationship between ARDS and AKI prior to COVID, is this finding that AKI increases your mortality. One of the first studies looking at this was done in 2005, and this was an international cohort study over 23 different countries and 54 ICUs. And if you had AKI, your mortality increased. Now, to get AKI in the ICU is not straightforward. First of all, you're competing with getting lots of fluid, so that automatically reduces your creatinine. And then the second thing is you lose muscle mass. So to actually have got to the point where your creatinine goes up, it takes a bit of effort and indicates there's probably quite an amount of damage in the kidney. Looking exactly at people with ARDS, a study from France several years later in 2014 found that if you had any kind of AKI in the setting of ARDS, you were more likely to die, and you were also more likely to have medical comorbidities associated with it. We looked at AKI in the lung-safe cohort. So again, this is data predating COVID. And I'm using this, and I'll explain a little further why I want to look at this cohort of patients. So lung-safe was a large observational cohort study, and it very much like the COVID Critical Care Consortium, it's a worldwide effort to try and understand ARDS better and better understand the real world management of it. It was published in 2016, and it found that but nearly a quarter of patients who are mechanically ventilated in an ICU have ARDS. It's under-recognized. It has a very high mortality rate of about 40%, and key evidence-based interventions are underused. And we used this data set to determine the hospital mortality in people who had moderate to severe AKI in the early stages of ARDS. So we specifically looked at a population of patients who developed AKI within 48 hours of being mechanically ventilated. And we found that most patients who presented with ARDS were only about 1 day in the hospital before they came to ICU. We excluded people with chronic kidney disease, we excluded transfers because we wanted a very pure population. And also the way that this data set was designed, they hadn't included the kidney in what they were looking at. And this is really to reduce down the number of data points, because if you have a data set with too many data points, nobody's going to fill it out. So the kidney got dropped, but we'd still managed to eke out some findings. And I think it's going to be particularly useful to compare this data set with the COVID cohort. So as I said, the COVID cohort by August of last year had 7,000 patients recruited, but as I've heard today, it has even more since. And again, similar to LungSafe, an international multi-center observational clinical studies, and this time very specifically focusing on COVID-19 rather than all comers with ARDS. And we've used this data set to, very similar to our previous study, look at the hospital mortality in people who've got moderate to severe acute kidney injury, looking at its prevalence, looking at the risk factors, and particularly looking on the relationship between shock and AKI. So the main differences between the two cohorts in terms of diagnosing AKI is that the KDIGO criteria is something we can use when we're looking at the COVID Critical Care Consortium. So staging acute kidney injury is not entirely straightforward, and it's not an exact science. Generally, one needs to know a baseline renal function to actually be able to stage it. To have a baseline renal function means that you have to have been in the hospital 1 year beforehand, and that's actually selecting out a patient group that's not probably reflective of the entire population group. We didn't have that with LungSafe, so we had to make some modifications so that we have essentially melded stage 1 and 2 into what was mild moderate AKI, and then stage 3, which was tripling of your creatinine or renal replacement therapy. But what's common to both of these data sets is that we only selected patients without a history of chronic kidney disease who were mechanically ventilated, and we had data on their kidney function within the next 48 hours. So it's quite a pure population of patients, and it allows us to directly compare patients who come in with generalized ARDS with patients who come in with COVID-related acute hypoxic respiratory failure. So I'm just going to point out, we had over 2,000 patients in the ARDS cohort, 1,900 of which were on mechanical ventilation. 61% had no evidence of AKI, 24% would have fallen into stage 1 or stage 2, and 15% had severe AKI in that they either required renal replacement therapy or the tripling of their serum creatinine. And that's within 48 hours of going on a mechanical ventilator. Now, these numbers are quite different from COVID. So for the COVID cohort, when at the time point that I've been looking at it, and we'll probably update it again, is that there's more than 7,000 people in the cohort, of which 4,000 people were mechanically ventilated. And as I said, we didn't include people with chronic kidney disease, people who were transferred, or people with missing data. 84% had no signs of acute kidney injury within 48 hours. And only about 14% had mild to moderate AKI, and a smaller percentage again had stage 3 AKI. And I think this is important. This is only within 48 hours. And obviously people can go on to develop AKI after this, but most people develop their AKI within 5 days of going on a mechanical ventilator. Comparing the cohorts in terms of their demographics, older, they were male, they had a higher body mass index, they're more likely to be diabetic and have chronic liver failure, and having COPD was protective. In the COVID cohort, we found that patients were older, but there was no difference in gender. So if you developed AKI, you were equally likely to be male or female. And this is interesting because it's more a male predominant condition. You're not more likely to be heavier, but again, I think all of them were very heavy to start with, so it's difficult to have a bit of a difference when everybody has a high BMI, and there's no difference in the prevalence of diabetes. If you have hypertension and chronic cardiac failure as a pre-existing medical condition, and chronic liver failure. So again, it is a different cohort of patient that gets COVID-related acute hypoxic respiratory failure compared to ARDS. And some other interesting differences between the groups. And I think this is important as we try to understand the pathophysiology of this disease, that we don't kind of lump it in as that this is ARDS. It probably is different. But I think what's important, what I'm trying to highlight here, is within the severity of the respiratory failure that was present with COVID-19 versus ARDS, and I've highlighted here in yellow, people with COVID-19 had much more severe respiratory failure compared to standard ARDS. So predominantly, if you had AKI requiring renal replacement therapy, nearly 80% of your patients had severe ARDS, and this compares to 30% with ARDS that wasn't related to COVID. If you have had AKI, you had a more severe phenotype in that your pH was running lower. And I think one of the other big differences is that, we frequently say, oh, they got AKI because they're cardiovascularly unstable. It was because they were hypotensive. This wasn't a predominant finding for COVID patients. So when we look at ARDS, there's a wide range of SOFA cardiovascular scores, but most people having a SOFA cardiovascular score of 4 if they're severe AKI. In COVID patients, nobody had a SOFA score within day 1 of their admission. Most of them, if they were sick, had a score of 1. They were on low dose pressors. So I think these are important differences to be considered when we try to basically dissect out the differences between COVID and ARDS as we've been used to managing it. The other thing that's interesting about this is, despite not having a severe cardiovascular phenotype, and despite their AKI not being as predominant, the outcomes for these patients were much worse. So the mortality for ARDS in a patient who didn't have AKI was 26% in the lung safe cohort, and this compares to 34% in COVID. For AKI or renal replacement therapy or stage 3 AKI, the mortality was 58% to 28 days in the lung safe cohort, and this compares to 66% in people who had renal replacement therapy requiring AKI or a tripling of their serum creatinine. So for each stage of AKI with COVID, there was an increase in mortality compared to those that didn't develop AKI, and this was greater than what we have seen for ARDS prior to COVID. The other thing is that of interest is that there's regional differences with regard to the risk for mortality. So compared to Europe, Africa and Asia, if you had AKI, you were more likely to die, whereas if you're from North America, you were less likely to die. And AKI, if you had your mortality from AKI wasn't affected by corticosteroid use. And this is probably reflecting that the fact that these patients are mechanically ventilated. Steroids probably have a role in preventing you requiring mechanical ventilation, but if you're developing the need for mechanical ventilation and you have AKI, steroids are probably not going to make a huge difference at that point. And again, something different from what we found for our cohort, our ARDS cohort, is that the platelet subcomponent of the SOFA score was associated with an increase in mortality. And again, giving a nod that there's probably some underlying thrombotic abnormality in this condition that really needs to be better understood if we're to manage it better. So in summary, both in ARDS and COVID-related ARDS, AKI is associated with an increased mortality, but there are important demographic, respiratory and cardiovascular disease severity markers in COVID-19 that are different from what we've seen in ARDS before, and there are geographic differences. We didn't look at ethnicity because I think it's very tricky to decipher reasons for differences related to ethnicity versus geographic area. And I think geographic area gives a little bit of a better information that we can use to try and tease out what made people more susceptible to AKI and what made them more likely to die in the presence of AKI. So I'd like to thank the rest of the Critical Care Consortium subgroup who've been involved in this study. And again, I'd like to just say that anybody else wants to try and contribute data or be involved with this this work, we'd be more than happy to have them come on board. So I'll stop there because I'm very aware that everybody has homes to go to or nightclubs to go to at 2 o'clock in the morning in Brisbane.
Thank you very much, Barbara. And I'm sorry if I mangled your name. Some of us have to go to work, some of us can go to sleep. I'd like to thank all of the speakers, and I would like to hand back to John in Brisbane to close out the meeting. Thank you very much, everyone.
Thanks, Giles, and thanks, Barbara. Great presentation. Look, it's really interesting to understand exactly, you know, lung safe, for example, and we brought John and Barbara on early on, a fantastic database of pre-COVID, and what we've got is a fantastic base of COVID, and the comparison between the two will be fascinating. So thank you, Barbara. Before I close out, I'm going to pass to our chair, Bob Bartlett, again. Thanks to Bob. It's 5 in the morning where Bob's got up, despite being leading the field of medicine for the last 40 years. Bob still get up at 5 in the morning and looks much better than I ever will, which is slightly annoying. But before I pass over to Bob, I'd just like to thank a number of people that have made this all possible. The Prince Charles Foundation, the ASARIC, ELSO, EGMONET, ANZIC, University of Queensland, Queensland University of Technology, the Gates Foundation, IBM, Minderoo, Aridia, Irish Critical Care Research Network, Wesley Medical Research, Queensland Health, specifically the teams in Spain and Italy. I get a lot of praise that I don't deserve. The real workers here are Gianluigi and his wife Gabriella for allowing him to be here. So grazie mille to Gabriella, and to Jackie and his wife Noelle, who also allow us to be here. So to them too, a huge thank you. And Queensland Health as well. So before I close, I'm going to pass a couple of words to Bob. I think it might be about 6:30 or 6:10, 7:10 in the morning, Bob, for you to give us your summary, and then I'll close out the meeting. Over to Professor Bartlett.
Thank you, John. And thanks to all of you for participating in this marvelous conference. We've learned a lot. I have been told that this will be available on video to the participants, which is really important, because I'd like to go back. There are thousands of things that I heard today that I did not know about, and they're going to have a great impact. So I would just say congratulations to all the participants. Thank you for participating. I would add my own thanks to Gianluigi and Jackie and Pauline in particular. I would like to thank Lauren, who's one of the people who was the host and for the presenters was crucial and was remarkably good at coordinating how to deal with COVID in Zoom land, and she did remarkably well. Thank you for that. And of course, finally, thanks to John Fraser, we would not be here were it not for John Fraser. So it's absolutely worth every minute of it. Thank you, John.
Bob, is fantastic, and we're very fortunate that you're better at physiology than you are at Scottish accents. Otherwise, we'd be up shit creek, mate. Thank you, thank you. Look, it's 2:15 in Brisbane, 2:15 a.m. in Brisbane. I've got a fantastic team here that have allowed it to help happen in Brisbane. We've had very little COVID. We've not been smashed like the rest of you. I think this is a humbling experience for me and our team here to have you as our panel of experts and to have the attendees. Throughout the day, there's been at least 100 people on this thing. There's been 500 plus people. This is recorded. This has been a place where we've come together, where we've shared concerns, when we've been honest about our lack of understanding, and when we've gone to other people across the world, whether it's from Vietnam to Michigan or whether it's from Hong Kong to Maastricht, we've all come together. There's very few specialties or professions like medicine where these opinions and this expertise would be provided for nothing. It makes me proud that I've chosen to be a doctor. It makes me proud to have the team that I have here. I'm nothing without them. So I get an awful lot of praise that I really don't deserve. So to my team here, still at 2:15 in the morning, thank you. To you that have joined us tonight, thank you. To the attendees tonight, but also to all of you that have joined us together over the last 18 months to create this family that is the COVID Consortium. Thank you so much. This is the end of the beginning, not the beginning of the end. We have so much potential to work with REMAP-CAP, to work with different studies. So well done. Thank you for your time today. Thank you for your time over 18 months. Pat yourself in the back. You deserve to. There are so few professions that would have given so completely and so selflessly as we have. And this is why we did the beautiful profession that is medicine. So thank you very much. Good night, good morning, good afternoon, and God bless. And we'll see you around the traps. Ciao. Bye.